We are live, you can start now.
A very good Sunday morning, everyone. After the enlightening and exhausting day one of PHONOCON 2022, here we are on the second day, all set box brains with some more interesting talks and discussions. We assure you that this day is also going to be filled with sessions nothing less than amazing and thought-provoking.
Having said that, we, on behalf of the organizing committee, take immense pleasure in welcoming each one of you to the spectacular second day of PHONOCON 2022. Let's kickstart the second day with an instructional course by Dr. Jaikumar Menon Sir, pioneer laryngologist and voice surgeon, a guiding light to young and aspiring ENT surgeons. Sir would be taking us through the basics of fiber optic endoscopic evaluation of swallowing. Delegates are requested to kindly post their questions in the chat box, which would be addressed at the end of the session. Over to you, sir.
Good morning, all. I think you can start the presentation straight away. We won't waste time for the introduction.
Yes, sir.
Good morning, everybody. So today we are going to talk about one of the key investigations in a swallowing disorder. That is known as FEES. As you know, the full form is Flexible Endoscopic Evaluation of Swallowing. And this is Miss Susan Langmore, who has pioneered this technique and contributed significantly to the development of swallowing disorders management. FEES obviously require a flexible, laryngoscope, not a rigid laryngoscope. Usually doesn't see the physiology of the larynx that well because you are holding the tongue and all those things. So a flexible is the ideal thing. So you can have the conventional flexible laryngoscope like this. You can use the chip-on-tip, which has got even higher quality. Or you can even use the transnasal esophagoscopy. If you have got that, that is a great equipment because you can also see the esophagus with that. However, in this talk, we are just concentrating on the FEES that to the pharyngeal part. It is preferable to have a suction port, but it's not a must. You must be knowing that, to have a suction port, the scope should be fairly big enough, at least 4.2 millimeter in diameter. So if it is not there, don't worry. If need a suction, you can always pass a small catheter down the other nostrils at the time of the examination, and you can do the scope through the other nostril. So if there is any chance of aspiration or there are a lot of secretions and pooling, if you want to clear it, we can put the suction through the other nasal cavity and suck out all the secretion. But if it is incorporated into the scope itself, then it is great. There is actually no need to put the suction tube. But if that is not possible, especially in a child, that won't be possible because you don't have a smaller diameter laryngoscope with a suction port. Now, position and anesthesia. It is ideal to do in physiological position. People eat and drink in the sitting position. So if possible, always try to do it in the sitting position itself. But not every patient may be able to sit that way because of their comorbid condition. So in that case, you can even do it under semi-reclining position. And if there is no other choice, patient cannot even sit in the, or be in the semi-reclining position, you can also do it in the lying position, even though it is not exactly a physiological method of swallowing assessment. Preferably don't use any anesthesia. You don't require actually. If the patient is very, very uncomfortable, you can just use one puff of topical anesthesia, 10% or 4% xylocaine into the nostril through which you are trying to pass the scope. Usually that is not required. You can put little bit of xylocaine jelly on the scope and pass it easily through the nasal cavity. Because too much of anesthesia might actually cause some problem. It may give a wrong value because anesthesia may make the swallowing a little bit difficult and you may have a wrong impression. So it is better to avoid too much of anesthesia. Now, there are two parts for the fees. First, you do the endoscopic evaluation of swallowing without any food. That means you pass the scope through the nasal cavity, to the nasopharynx, oropharynx, and into the laryngopharynx. So visualize all the anatomy and physiology of these structures without giving any food. We can also see the effect of swallowing by looking at what the patient is doing with his or her own saliva. Is he or she able to swallow it normally, or is he aspirating? All these things can be done without any food. So the first part of the endoscopic evaluation of the swallowing will be without food. So in that case, you have to look into the palatal movement. If there is a palatal paralysis, if there is a pooling of saliva that actually suggests the swallowing mechanism is not great. Is there laryngeal elevation? That's a key moment in swallowing. If the larynx is not elevating, then the swallowing is going to be in real trouble. So look for laryngeal elevation. Then look for laryngeal competence. Competence can be motor or sensory. Means larynx cannot close if there is a paralysis of the adductor muscles. It can also be incompetent in a sensory way, where the sensation is not very good. The larynx movement may be all right, but there is no sensation. In that case, also larynx will be incompetent. It's again, all these things can be both unilateral or bilateral. And finally, look for penetration and aspiration of the saliva. Penetration, of course, I suppose you all know. Penetration means food going down to the into the laryngeal introitus, but above the level of the vocal cords. Aspiration means it goes below the level of the vocal cords. Now we will look into each one of them. First is the palatal movement. So when you pass the flexible laryngoscope down the nasal cavity, you check whether the palate movement is normal. Is it unilaterally abnormal or bilaterally abnormal or totally normal? So you can watch a few of them. So here you can see the patient's right side of the palate is not moving. This is a right palatal palsy. Left side, it is closing of the nasopharynx from the oropharynx. So obviously, there is a palatal weakness with the possibility of nasal regurgitation. Now, sometimes the whole palate may be affected, especially this is a case of motor neuron disease where you know that it is a tongue and a palate which are likely to get affected in the early stage. So here, both sides of the palate may be affected. You can watch here.
One mother 10 were allowed one, two,
If you can listen carefully, you can understand that there is some amount of hypernasality because the palate is not completely cutting off. So palate is important not only for the swallowing, but also for the speech. So if the palate is not working, the tendency, the hypernasality, there's something like If I got a palatal problem, my speech will be like this. So that hypernasality can be clearly heard, and also you can watch the palate is not completely closing it off. So you can see that palatal movement is reduced. Next is looking for pooling of the saliva. A normal person will not have any pooling in the pharynx or in the oropharynx. So somebody who has got a pooling of saliva suggests that there is some problem with the swallowing mechanism, because normally when we are all awake, we swallow at least once a minute. So saliva is not allowed to collect there. It actually being drained down into the esophagus, into the stomach. But if when you are doing the scopy and you are seeing saliva pooling in either in the piriform fossa, that's a commonest site, or in the root of the tongue, base of tongue, then you should assume that there is something wrong with the swallowing. You can see this patient who has got a lot of swallowing on the left piriform fossa and partly on the right side too. We can also see the left vocal cord is paralyzed. Probably that may be related to that. So look for pooling of the saliva. They give some idea about the integrity of the swallowing mechanism. Next is laryngeal elevation. And whiteout sign is a very commonly used terminology. What do we mean by whiteout sign? When you are doing a flexible laryngoscopy, you get a very clear picture of the larynx. But the moment you ask him or her to swallow, for a split second, larynx goes out of vision and your scope touches the side wall of the pharynx, giving a whitish glare. So for a split second, you can't see anything. So this is known as whiteout sign, and that's a normal thing. If whiteout sign is absent, that's actually a bad prognostic sign, because the larynx is not elevating. That's a key moment in swallowing. If the larynx is not elevating, it will not come under the protection of the tongue base. Not only that, cricopharynx needs stretch to open. So when only the larynx moves up, the cricopharynx is stretched and consequently to open up. So we can see the normal and abnormal here. This is the normal. See that's a, each time watch for a split second you couldn't see that. You can see again that one. So that is the whiteout sign. That's a whiteout sign. But in swallowing disorders, especially when there is some problem with the suprahyoid musculature, when the larynx is not elevating, this whiteout sign will be conspicuously absent. We can watch it. So we are going with the scope down into the, we are also checking the palate, which we have already seen. Now we are going to the larynx. Patient is being instructed to swallow. You can see the Ryle's tube is on the right piriform fossa. Vocal cord movements are normal, not much of pooling, but patient is struggling to elevate the larynx and there is no whiteout sign, or it's very infrequent. Still trying to swallow, no elevation, larynx is still completely visible. That even that was not successful. It was only partly moved out, but there was no total whiteout sign. Still larynx is not moving. Still not moving out of vision. So this is known as the absent whiteout sign. It suggests that larynx is not elevating during swallowing. That's a major issue. So that's very important sign, very easily detected. Now look for pharyngeal squeeze. Now pharyngeal squeeze means the lateral wall and the medial wall of pyriform fossa come closer to each other. The lateral pharyngeal wall of pyriform fossa or the posterolateral wall of the pyriform fossa come and almost touch the medial wall. That is area epiglottiform. The interesting thing is that pharyngeal squeeze is abnormal in voice. It is normal in swallowing. So two functions of the larynx has got different mechanism. So normally when somebody is singing a high pitch sound, pharyngeal squeeze shouldn't happen. If it happens, that is not normal. But just to show that what is pharyngeal squeeze, I am showing a singer now here. So when she sings at a high pitch, you can see the lateral wall come and squeeze against the medial wall. So you saw that, that's the pharyngeal squeeze. Now, pharyngeal squeeze should be normally there in swallowing. If that doesn't happen in swallowing, then that's problem. So when there is a thyropharyngeal paralysis, you know that the inferior constrictor has got two parts, the thyropharyngeus part and the cricopharyngeus part. So if the thyropharyngeus is paralyzed, then you get this problem of pharyngeal squeeze is absent. We can see that now. This is very lax here. There is no movement from the lateral wall. Actually, when somebody is swallowing or when somebody is forcing a sound, they should actually squeeze. That's not happening here. So this is pharyngeal squeeze absent. Now look for vocal cord movements. That is very obvious. You have to look into the vocal cord movement. If there is any paralysis or a partial paralysis, that is known as paresis. So look for vocal fold paralysis or paresis. So here you can see the right vocal cord is paralyzed, left is moving, and right tube is through the right pyriform fossa. So you can see that movement is not very great on the right side. So look for that kind of findings. Now laryngeal sensation is very important. How do you do to check laryngeal sensation? There was an instrument called laryngeal sensory testing, LST. And when you compare laryngeal sensory testing with FEAST, we used to call it FEAST, flexible endoscopic evaluation of swallowing plus sensory testing. But nowadays that is not available. We can easily do that testing, laryngeal sensory testing by touching the arytenoid with the tip of the scope. When you touch the arytenoid with the tip of the scope, the arytenoids will adduct. This is known as the laryngeal adductor reflex. Another technique, if the larynx, even with the touching, if the larynx is not adducting, then the sensation is bad. Another technique will be to try to pass the scope into the trachea. So normally unanesthetized patient will actually cough out when you negotiate the glottis. But if there is a paralysis, sensory paralysis, you can easily do the tracheoscopy. You can watch here. So that's the anterior commissure. I'm just trying to see, I have entered the trachea without much problem at all. No anesthesia. Could go up to the carina. So that means that sensation is not there. Now look for penetration and aspiration. We have seen that penetration is above the level of the vocal cord but into the laryngeal introitus. Here again, you can see the right vocal cord is paralyzed. There is a lot of pooling saliva and actually it is falling into the laryngeal introitus but without going into the larynx proper or the trachea. That is penetration. You can see there is a lot of penetration happening. Now, aspiration means it has gone beyond that. You can see that there is plenty of saliva is going down into the larynx. That is huge aspiration. No food has been given, but we can see saliva going down into the larynx. And also you should very importantly look for the nasogastric tube position. This is very important. We all know that the ideal time for keeping the Ryle tube is only 1 month. Many times we prolong it up to 3 months before going to gastrostomy. But looking at the position of the NG tube, we can actually make that decision. If the nasogastric tube is actually going through one of the piriform fossa, usually it goes through the opposite piriform fossa. If you put the Ryle tube through the right nostril, it will go through the left piriform fossa and vice versa. If it goes through the apex of the piriform fossa, it is okay. It's not going to create much problem. But sometimes you will see that the larynx, the Ryle tube go through the midline just behind the posterior interarytenoid region. That is very unfavorable. It will produce a condition known as posterior cricoarytenoid myolysis and consequently laryngeal damage. We can even have vocal cord movement abnormalities. So this is the ideal thing. You can see the Ryle tube is through the right piriform fossa apex. That's fine. That they won't create much problem. But if it goes like this is more of a problem. You can see that it goes right in the midline, and you can also see already excavating ulcer. You can see that an ulceration is being happened. The arytenoid mucosa is being eroded. So deeper to that, it is a posterior cricoarytenoid. And if the tube is kept for long, the muscle will get damaged. So this position is unfavorable. If you see that, then that suggests that it is high time you change the Ryle tube into the gastrostomy. So with that much of basic information, now we go into the feast proper. That means the second half. We are doing the feast with the foot. So footballers, there are two methods of going at it. One is that you start with the liquid, go into the semi-solid, and finally solid. But there is another school of thought who say that from the patient's history and from the watching the act of swallowing, you know which food is more difficult for the patient and which is less difficult for the patient. So they say that you start with the least difficult. Suppose patient has got less difficulty with solid. Start with solid or semi-solid. Like, the neural vocal cord paralysis may have more problem with the liquid because it aspirates easily. So both these methods are followed by many people. You can choose whichever one is comfortable to you. What is more important is that you should be always ready to expect and deal with an aspiration if it happens. And all the above described points will look again with the scope, with the foot in position. In addition, you will also look for premature spillage. Should also look for cough sensitivity and efficiency. That will come little later. And finally, your swallowing therapy is going to be dependent on this. So you will also try to do different options. Of course, the time doesn't permit me to go into the details of all therapeutic techniques. We will just show one or two. So usually one of the commonly used technique is the commonly used material is the ice chips. The advantage is that it is very small. It is only clear water. Even if there is some aspiration happens, nothing is going to happen. And not only that, ice chips is cold. So it actually gives sensation. Some people who cannot really actually initiate swallow, for them it will be better. For semi-solid, you can use pudding or yogurt with some coloring agent. Usually blue or green color is best seen in the endoscope. So you can use that. So you can modify according to the food available there. Only thing is that you should understand the pathophysiology and should be ready in case an aspiration happens, you should be ready. So you should start with little. Don't give lot of food and then create trouble. So nasal regurgitation. If there is a palatal weakness, we have seen the palatal weakness. But what will happen if the palatal weakness is there? You will see lot of nasal regurgitation. See, already in the nasopharynx, into the nasal cavity, the food has already regurgitated. So this suggests patient has got a nasal regurgitation. So before giving food, we might have already diagnosed a palatal incompetence when we do the scopy, when we did the fees without any food material. So those kind of patient may have this real nasal regurgitation like this. Next is tongue-based dysfunction. So tongue-based, when the tongue base is not functional, you can have two findings. One is known as the premature spillage. That means before patient initiate the voluntary swallowing act, the food kept in the oral cavity go to the larynx. So larynx is called unaware. Larynx is not ready. So chance of aspiration is high. So a normal person will pass the food bolus from the oropharynx to the laryngopharynx only when he or she wills. Without attempting the swallow, food sometimes will go if the tongue base is not good enough. This is known as the premature spillage. We can see that now. So we have just given some food. Ask her not to swallow now, but even before she swallowed, you can see that it just spilled out into the pharynx and into the oropharynx. So this is what is known as the premature spillage. That means food going down into the pharynx when patient hasn't actually started swallowing, when without intention, unintentional transfer of food bolus from the oropharynx into the laryngopharynx. And the second finding of a tongue-based dysfunction will be vallicula. In the vallicula, there will be residue, stasis. So you can see again. There's no audio in it. Can see on the epi and the vallicular side, you can see plenty of material. Food bolus is collecting there like that. See that is in the vallicula. There is plenty of footballers, not only in the vallicula but also in the pyriform fossa. But here we are bothered about the vallicula. You can see that there is plenty in the vallicula here. So that is the second finding of a tongue-based dysfunction. Absent whiteout sign we have already described. So we will again confirm with food. So when the food is given, larynx should elevate. Then only the food will be transferred, bolus will be transferred, larynx will get under the protection of the tongue base, and only then the cricopharynx will open up. So if the whiteout sign is not there, that's a bad sign. You can see it again. So you can see the Ryle's tube position, and we have given food. The blue colored, there is some colored liquid is given. Ask the patient to swallow. But larynx is being completely visible. No whiteout sign, no missing of the visualization of the larynx, suggesting that larynx is not elevating. Pooling in the pyriform fossa. So if you get pooling in the pyriform fossa, if it is unilateral, you can always be very sure that this is a thyropharyngeal dysfunction. We have seen that the inferior constrictor has got two parts, the thyropharyngeus and the cricopharyngeus. Thyropharyngeus forms the funnel part of the laryngopharynx, cricopharynx forms the stem part. You can have different combinations of dysfunction. You can have isolated thyropharyngeal dysfunction. You can have isolated cricopharyngeal dysfunction. You can have combined dysfunction. Suppose there is a unilateral thyropharyngeal dysfunction. What will be the finding? That particular pyriform fossa will be very big. That means the Bastian sign will be absent. The lateral wall will not compress, and there will be plenty of pooling on that side. Or asymmetrical pooling. If there is a lot of pooling on one particular pyriform fossa, you should assume that that thyropharyngeus is paralyzed. We can watch it. So here you can see that here the squeezing of the pharynx is there on the left side, but right it is so spacious pyriform fossa that suggests thyropharyngeus is weak. Now, this patient also has bilateral. There is some pooling here. So when you have got a bilateral pooling in pyriform fossa, it suggests two possibilities. Either it is a bilateral thyropharyngeal dysfunction, which is not very common. In that case, both will be equal. Here, this is less only. The right side is more. But it is more likely that patient has got a cricopharyngeal dysfunction. Because if the cricopharynx is not opening up, food has to be there in the thyropharynx only. So naturally, even though one pyriform fossa is normal, some food will collect there also. But you can still assess the more affected side by looking at the more spacious nature of the paralyzed pyriform fossa, absent Bastian sign, more pooling, all these things. So it will give a clue. Even after multiple swallow, there is still some there. Now come to penetration and aspiration. We have seen penetration means into the laryngeal introitus, but above the vocal cord. Aspiration means below the vocal cord. Obviously, aspiration is more serious type. Now, penetration and aspiration can be primary or secondary. What do you mean by primary or secondary? Primary means larynx is incompetent. When the food comes, larynx doesn't close, so food goes down. Secondary means larynx is competent, but pharynx is not competent. So when the food goes to the pharynx and when the pharynx is not opening, what will happen? Like the previous video, the food will get collected there And after some time, the larynx has to open up because patient cannot be in the apneic state for long. He has to open up the vocal cord to breathe. Then all the collected food will go to the larynx. So that is secondary aspiration. So you can have primary and secondary. Primary can be again sensory or motor. So you can see here on the Ryle's tube. So this is penetration only. You can see the food is going here, but not into the laryngeal lumen as such. Above the level of the vocal cords. While aspiration means it has gone beyond. This is massive. See that? The blue colored food, the dye given is actually gone to the larynx. So it is massive aspiration. Now, penetration and aspiration can be secondary also. I already explained. See, if the pharynx is not working properly, when the food goes down, pharynx doesn't open up, food stays there. After some few seconds, larynx has to open up to start the breathing. Then all the food goes go to the larynx. So this is known as the secondary aspiration. Again, it can be penetration and aspiration. This is a lateral medullary syndrome case where the pharynx is abnormal. Larynx is reasonably okay, but pharynx is not opening up. So what will happen after some day, the food will start going to the larynx. Can see that food is going down here. This is secondary penetration, and further going down is aspiration. Now, we told about the possible swallowing therapy, which we can actually identify during the phase. You know that you need to understand the physiology a little bit. And we'll discuss few cases, few types. You should understand what is essentially the difference between head turn and head tilt. Head turn means, if I say I got a right head turn means, I look at my right shoulder, means I turn my chin to the right side. So this is a right head turn. So head turn means you turn the head or you tend to look at that particular shoulder. Okay. Tilt means you tilt the head such a way that that ear touches the shoulder. So this is the difference between turn and tilt. It has got diametrically opposite effect on the swallowing. Right? I will show it. This is a right head turn. This is a right side. This is a left side. So when the patient is turning the head to the right, that means looking at the shoulder, what will happen? The right piriform fossa will get obliterated so that food will go through the left side. Watch. You can see the difference. The left piriform fossa become very big and the right has obliterated. So patient has got a right-sided paralysis of the pharynx. You should ask the patient to turn the head. That means look at his right shoulder. Then what will happen? That piriform fossa will get obliterated and the left will become much bigger so that food will actually go through it. So this is turn. Now tilt is different. Tilt means you touch that particular shoulder with the same side ear. Here, whichever side you do, that side become open up because of the gravity. So this can be done in sitting position or lying down. So this patient is lying down on her right side. that is on this side. So this is a head tilt, mind you, not a turn. So see what the foot will go through. Because of the gravity, it will go through the downside. So when you do the head tilt, it will go through the same side. When you do the head turn, foot will go through the opposite side. This is very important concept you should be understanding when you plan the swallowing therapy. Now, there are many techniques like the Mendelssohn's maneuver, supraglottic swallowing technique, supraglottic, Massaco's maneuver, chin tuck, effortful swallow. We are just showing two. Mendelssohn's maneuver means you keep the food inside the mouth, then catch hold of the thyroid and the hyoid and pull it upward and forward. That means it's like happening in a normal swallow. So in a person, this you do it in a case of when the laryngeal elevation is not there. We have seen that is a very important thing. If the whiteout sign is absent, that means the larynx is not elevating. In those kind of patients, we keep the food in the mouth and you try to imitate the natural act by catching hold of the thyroid and hyoid and pulling it up and anteriorly. So that is known as Mendelssohn's maneuver. It will actually bring the larynx up, cause the cricopharynx to open up because of the stretch. You can see that. That is a Mendelssohn maneuver. When this happened, when I lifted up here, watch again. This. Again, this. So you're catching hold and elevating it. So that is the Mendelssohn's maneuver. Supraglottic, you all know that this is in laryngeal incompetence. You ask the patient to hold breath and then swallow so that the food doesn't actually go down into the larynx. In supraglottic may not be that easy for many patients to do that. So supraglottic is easier. So what is supraglottic? Again, in laryngeal incompetence, ask the patient to keep the food in the mouth, hold breath, and do the bearing down maneuver like this. You just pull on like that. When you do that, the larynx jam against the hemilarynges, jam against each other and close the larynx. So the chance of aspiration is gone. We will see how does the supraglottic work. You can see that this is the supraglottic. So tightly closing. Watch again. That is it. It's very tightly closing. Very, very tightly. Hold both hemilarynges, clash against each other, merge against each other so that it cuts off the chance of any aspiration. So it's a very efficient technique in many laryngeal incompetence. That is supraglottic swallowing technique. So this is what I wanted to convey in this instructional course. Of course, fees is a big topic. Swallowing itself is huge, and fees is an examination which almost all of you can do that, provided you have got a reasonable flexible laryngoscope. You need not have the high-end flexible laryngoscope. Even a conventional flexible laryngoscope without a suction channel, you can even do that. But if you understand the physiology of the swallowing very well, then it is not that difficult. So understanding the anatomy first, physiology first. You should be thorough with that. If you know the anatomy and physiology, it is fairly easy to identify the pathoanatomy and pathophysiology. More importantly, pathophysiology with a flexible laryngoscope. And vast majority of the swallowing disorders are actually in the pharyngeal stage. Very complicated, very complex stage happens during just 1 second time. So many things happen. So all this can be beautifully deconstructed and analyzed. And we can reach what is the possible problem? What are the possible constituents of this swallowing disorder, and how well we can actually correct? So most of things are common sense. There is not much of high-end science or anything. But if you understand the physiology and you are visualizing the pathophysiology, many times you can design simple swallowing therapy techniques and make the patient eat and drink again. That's not a small thing. That's quite a big thing. It is quite a gratifying thing. Many patients, there are plenty of patients who are unfortunate enough not to eat or drink normally. So deglutology is a fantastic specialty, and learning to do fees is one of the earliest step to step into the realm of deglutology. Thank you very much.
Thank you, sir.
So we now have a couple of questions that has come from the delegates. Sir, shall we address the questions?
Ma'am, we don't have sir online.
Sir has gone. We shall address the questions and reply via mail to those who have sent in the questions. Thank you so much, sir, and thank you so much, delegates. Let's move ahead to Hall A, wherein we have the most awaited oration on innovations in laryngeal surgery by Dr. Stephen Zetels. This would be followed by a keynote address on the concept of laryngeal pacing in bilateral vocal fold paralysis, past, present, and future by Dr. Andreas Muller, sir.
We would be resuming our sessions in Hall B at 1 p.m. Looking forward to have you all boarded with us for some really interesting talks by our eminent ENT surgeons.
Thank you so much. You guys sit, we'll take a photo.
Good afternoon, ma'am.
Hello,
Good afternoon, ma'am. Yeah.
can you hear me?
Yes, ma'am. Yes.
Okay, I just have to stay online till the talk
Yes,
gets
ma'am.
over.
We will start the streaming when the streaming is on. Your recorded talk we will start by 1 o'clock exactly.
Yes, you will not show me at any point, right?
At the end of the talk, if there are any questions from the delegates, ma'am, we will post it to you. You can be live and answer the
But I
questions.
don't have to come on the screen for the delegates, right?
Not for now, but post while you're answering, you can start your video and you can give the answers.
When?
Once your talk is done, ma'am.
No, I would rather not. If it is
Okay.
okay.
No worries, ma'am. Yeah.
I'll, So
In
I'm,
case you have question, we have questions, we will post it to you.
so that means I don't have to say anything also.
No, ma'am. We will have that interaction live.
Yeah, you have interaction live.
Yeah, only for the question and answers.
So you want me to stay on the screen for people to answer questions?
Yes, only after your talk, after recorded talk for 15 minutes.
Okay.
If there are questions, we will post to you live. You will have to answer them live only, ma'am. Is that okay with you?
Okay, but then I am on a phone. I'm not at the laptop today.
No worries, ma'am. No worries. This is okay. This is okay.
I'm looking fine to you just
Yes,
now.
yes, ma'am. Yeah.
So this is how I will appear to people if they want to, if they have any questions.
Yes, ma'am. Yes.
And can you hear me well? Because I'm in a function and some conversation is going on in the next room. Is that okay?
No, ma'am. Your voice is very clear. It is okay.
Okay, thank you.
Yeah.
Then
Okay.
listen. So
Yeah.
if I'm on this and I can't see my talk because I am on the screen.
Okay.
So can I, will you, I mean, till when my talk gets over, I will come back here. Till the time, I will also watch the talk.
Yeah, you
on
will
the
also watch and we can be on mute, ma'am. So if there, in case there are questions, we will post or else we'll just move on to the next session.
Okay, fine.
Okay.
I'm ready. Huh?
Okay, ma'am.
I'm unmuting myself just now. And I'm
yeah.
also going off video till the talk gets over.
Okay, ma'am. Yeah. Should be
Thank
okay.
you.
Yeah, thank you.
Ma'am? Good afternoon, all of you. We welcome you all once again. Good afternoon, all of you. We welcome you all once again. We are back with some of the distinguished ENT surgeons from all around India presenting their talks on voice. Kindly sit back and be all ears to the voice.
Delegates are requested to kindly post their questions in the chat box, which will be addressed at the end of the session.
Thank you.
It is my pleasure and privilege to be speaking to all of you on this platform today, and I will be speaking to you on breathing, resonance, and the professional voice. We all know that voice is produced when air from the lungs sets the vocal folds into vibration, and the sound pulses then emitted traverse the vocal tract to emerge through our mouths as sound. But what is produced at the level of the vocal cords is very different from what comes out of our mouths. And this happens because of resonance thanks to our vocal tract resonators. Every musical instrument has a vibrating source and a resonating chamber, and our vocal instrument is no different. Our vibrating source are the vocal cords, and our resonating chamber is the vocal tract, which is like a tube. But what is special about it is that we can change its shape and size unlike any other instrument, and that allows us to produce this huge repertoire of amazing sounds that no other species on this planet can. So the word resonance comes from the Latin word resonare, which means to resonate, resound, or boost. So what is actually happening here is that the vocal cords are producing a fundamental frequency and several overtones are harmonics at the same time. But only those that match the natural vibrating frequency of the vocal tract get resounded or boosted or amplified, and the others get dampened. So let's go into a little deeper into this. According to the laws of physics that govern the tube and chamber resonances, we know that when sound enters a tube, some frequencies will cause a standing wave to happen in it. And when that happens, the tube will resonate with its maximal intensity. Now, this can be calculated from the length of the tube and the speed of the sound. Since our vocal tract is a tube, we thus know that for an average vocal tract of human beings, the maximum resonating frequencies are in the regions of 500, 1500, and then 1000 hertz apart, so on. Now, these maximal peaks of resonance are known as formants, and they distinguish human sounds. They happen regardless of the fundamental frequency. So, practically everything that we speak falls within the first one or two formants, and for singing, the third and the fourth formant are important. Now, these are based purely on physical characteristics. So, what can happen if we are able to change them? So, by changing the configuration of the vocal tract or changing the shape of the tube, what we can do is essentially change the different peaks of different frequencies within this sound spectrum. That is why we are able to distinguish sounds, and that is why an A will sound different from an O and an I will sound different from an E. Every shape is characteristic of a particular sound. So what resonators are doing is that by changing the shape and modulating the airflow in tube, they are giving us distinguishable sound. They give us volume. And they give us quality. Now, because no two vocal tracts are exactly similar in structure, nor will they move exactly in the same manner, each one of us will have his or her unique voice, which is almost like a voice print. This is also the reason why I sound different from myself when I have a cold or a cough. Coming to the resonators one by one, the larynx is the first resonator. It's responsible for the fundamental frequency, the range, and the way voice is produced at the level of the glottis. A lower larynx and a freely mobile larynx are optimal for excellent voicing. There are certain areas of the larynx near the rim of the epiglottis, which by their sheer geometry are responsible for producing very high resonances, and you need to be able to bond with a geometry or a larynx like that to sing such notes. The pharynx is the largest resonator. It is the first place where sound is first received, and clearly having a relaxed and open throat is very important for further modulating the sound that comes in it. Now, the movement of the jaw affects the length of the vocal tract. Hence, having a tight or a constricted jaw will affect the quality of the voice being produced. In singing, bringing the jaw forward or dropping the jaw is considered an important tactic because it allows singers to raise their voice without straining their larynx and to keep the intensities of different formants equal while singing. Now, the tongue and the lip add to the resonance by modifying the vocal tract length, by changing the shape of the vocal tract, and none of the consonants and vowels can be formed without the help of these two organs. The soft palate. This moves continuously when we speak. Should it not close the nasopharynx us from the oral cavity when we are speaking, practically everything we utter would sound the same. And in my opinion, this is a very underrated organ. In singing, lifting the soft palate gives a ring or a brilliance to the voice. It is helpful in the quick intake of breath during singing, and acoustic feedback to singers is important while singing, given by the nasal provided. Hands, jaws, gestures are often used by singers to unknowingly modify the length of the vocal tract or aid in ribcage expansion and often used in performances. So it is clear that understanding how resonance works is important to sing. However, to achieve a level of excellent singing, it's not enough. Let us listen to this. May I add proudly that she's my mother. She's a Hindustani classical singer based in Nagpur. Now, to be able to sing like this, in addition to resonance skills, we need to add breath support and breath training to our training. And here is the role of understanding how breath works. All speech sounds require airflow. It is clearly the foundation on which voice rests. So, in normal breathing, inspiration occurs when the diaphragm and the external intercostals contract to expand the rib cage. Now, this expansion is a 360-degree movement. There is a vertical expansion, there is a front to back expansion, there is a side to side expansion, and the lower ribs are lifted in a bucket handle kind of manner. Expiration in normal breathing is completely normally passive. What happens when we sing or speak is that the sheer volume of air used is significantly more. The inhalation is quicker, much quicker. It's diaphragmatic. It must be adequate. It can be from the nose or mouth, doesn't matter, depends on the preference of the singer or need of the moment. But the exhalation is always long, purposeful, and controlled. So, what you're achieving here is a balance between the air which is leaving the lungs through the glottis to be made available for speaking and with the help of support provided by the abdomen. At the same time, it is important to be able to snatch in that quick breath and not let the ribcage collapse completely while continuing to sing or speak. So this is achieved with the help of internal extracondyls and rectus abdominis muscle, especially its lower belly. It has been given special importance in several musical texts and cultures, and the role of other abdominal muscles like the obliques must not be overlooked. So the way we breathe has a direct impact on the quality of your voice. Ideally, a combined thoracic with abdominal breathing which allows for a full expansion of the rib cage is ideal for adequate breath support during singing or speaking. So now we know that technique is nothing without efficient breathing. However, the demands that today's world places on professional voice users to become the vocal athlete is important that you increase fitness. Hence, developing strength and coordinations in muscles used for respiration is essential, and at this, the importance of core and the muscles of the pelvic floor must not be underestimated. And training for overall fitness should be an ideal goal for every professional voice user. Projection is a skill that professional voice users must be familiar with. It allows you to raise your voice without straining at the vocal cords. Now a word about the posture. Any issue with cervical spine, shoulders will impede laryngeal stability and movement. Any problem with the chest, spine, pelvis, knees, all the way to your feet, the way you stand, what shoes you are wearing will affect the function of the diaphragm and ribcage expansion. Hence, whether you are sitting or standing. The spine must be erect, shoulders relaxed, head facing forward, feet planted firmly on the ground, and attention to posture is important. The effects of resonance can be seen by artists performing in mimicry. You hear Sugandha Mishra here.
तो भाई और बहनों, अभी रेडियो चल रहा था लेकिन पुराने रिकॉर्ड्स जैसे
and dubbing.
मैं जिंदा थी मुकेश, सांसें चल रही थी मेरी।
तुम्हें सब कैसे पता?
और तुमने मुझे जिंदा ही काट दिया।
Mona Shetty is a famous Bollywood dubbing artist.
अब मैं आपको और परेशान नहीं करूंगी और जो भी हो जाए मैं यहाँ वापस नहीं आऊंगी।
When I did the dub for Raz.
Resonance styles are also seen when in singers and artists. For example, we know Hemant Kumar for his closed voice. We love Kishore Kumar for his open voice. And we remember Mukesh for his nasal voice. Now, these can be a matter of structure, or it can be a matter of preference chosen by the singer or the artist. Now, about some special resonances. The singer's format is the singer's ability to sing in very high notes. These are used in opera, where the singer can project his voice above the orchestra like this. And although this can be a learned skill, these are indeed very special people who can sing like that. Now, the whistle is the ability to produce extremely high registers, and this is because of a certain geometry of the larynx. You have to be born with it, and Maria Carey is one of the few people who can do it. Overtone singing is the ability to amplify two overtones at the same time, and this is a learned technique practiced in some cultures like Tibetan chanting. A word about the color of the voice. It suggests emotional content, refers to where resonance is felt during singing. Registers refer to the way sound is produced by the glottis, and the nada refers to the origin of resonance within our certain sites in our body and has been referred to in our ancient texts since the time of the Vedas. So at the core of a free voice rise resonance and breath, and it is clear to see where this singer is going wrong. There's plenty of scope for improvement, and same goes for this man here.
मैं जॉब करता हूँ मार्केटिंग का। अब मुझे काफ़ी प्रॉब्लम हो रही है बात करने में, लोगों से बोलना चाहिए। लोग काफ़ी मेरी बात समझ नहीं पा रहे हैं, उतना लाउडली बात नहीं कर पाता हूँ, काफ़ी लोग समझ नहीं पाते बातों को मेरी। इसी प्रॉब्लम को सॉल्व करने के लिए मैं यहाँ पे आया हूँ। It's clear why they are ineffective and how they can improve. Now let us see how perfection sounds like. Almost flawless. An epitome of effortless singing. She will stay in our hearts forever. This is how effortless speaking sounds like. We can feel and listen to the ease with which he talks. When there is resonance, the speaker can feel it and listeners can hear it. So how do you go about telling this to our patients? We educate them. We tell them about the laryngeal mechanism. We tell them how voice is produced. We teach them to take care of their voices. And then we work specifically with resonance and breath with various techniques like these. They look silly, they feel silly, but they're extremely effective in carrying your voice much forward. Finally, it is being aware and mindful of the effect of stress on your body and how constriction, restriction anywhere in the body from head to toe, the effect it will have on your voice, and be willing and able to work on relaxation. So, in other words, it's exploring the connection between mind, body, and voice that will finally free your voice and take it to its optimal capacity. So, it's neither the instrument, neither it is the training. Some people are born with it, some people have to learn it, but everybody has to practice and endure to have that unforgettable voice. Thank you very much.
Good afternoon, friends. I'm just going to make you a little bit aware of the challenges that we face in our day-to-day voice assessment clinic. Now, gone are the days when you can actually put a laryngoscope in someone's throat and just make a diagnosis. That is okay for organic and structural regions where you have a polyphony nodule. But in absence of any structural problem, you are dealing with neurogenic or functional problems where the appearance is normal, and therefore you have to rely on assessing the voice itself, and it becomes very subjective. Again, to overcome that, we have come with standardized protocol to add more objectivity to this whole process. And this protocols involve a proper case history, self-assessment of the patient, and so on and so forth. So I will point out certain problems and pitfalls inherent in this so-called objective process as to where you could go wrong, and maybe not go wrong, but keep an eye on that. First and foremost, it is very important that you make the distinction and convey to the patient that it is only the voice that we are going to assess, not a speech problem, because certain patients don't have the distinction between a speech problem and a voice problem. Secondly, they are not more forthcoming or more understanding as to how to convey what has gone wrong with their voice. So at this point, it is very important that you can take the relatives into confidence and tell them that what has changed in his voice, because when the patient tells you it's not the same as before, you don't have a clue as to what the before was and what has actually changed. So that becomes very important. And then avoid asking any leading questions only, but sometimes you don't have to recourse to them if you have no other choice. Now, the VHI index form that you generally hand out to the patients, which it ranks from 0 to 4. Now, as you can see that 1 and 2 almost never and sometimes tends to overlap a lot of times. I've noticed that, and it usually is to do with the emotional quotient of the patient at that particular moment. And that obviously can change in different settings. And if you see the part 3 of this form, it is completely based on the emotional status of the person. So obviously, these markings that the patient makes, apart from the 1 and 2, they usually swing from one side to the other. And it becomes even more difficult when you are doing a follow-up assessment of the same patient after some time. And therefore, paying weightage on this VHI index has to be taken with a little bit of caution, and remember the inherent problems there. Then coming to the respiratory assessment, the MPT is perhaps the most commonest test that everybody does. Now, more important thing here is how to clock the timing of the MPT. Generally, the patient just utters his vowel, and at the end tends to trail off, and then the intensity changes. Now, do you actually end it where the intensity is going to change, or you clock it till he actually stops uttering any sound? The general consensus is you measure the complete sound, but try 2 or 3 runs and then take an average so you come down to a reasonable idea of what the MPT is going to be. It is also very important to ask the patient not to change the pitch and intensity, which obviously is difficult to convey, but try and record it at his mid-intensity, because obviously change in intensity is going to affect the MPT. Also remember the kind of patient that you are dealing with. If it's a professional singer, they have a great control over their larynx, and they're masters at breath management. So they can actually produce a normal MPT. But remember, a normal MPT in a singer was probably low for him. His normal MPT would have been much higher. So these are small points that you would want to keep in mind when you're assessing those patients. Now, as for respiratory assessment, again, if you go in for a spirometry, there are inherent problems there as well, because first, the technique of the patient itself is very important. So you have to have a person to explain to them properly as to how to blow in, because forcefully blowing in or delaying in blowing in will give you the wrong FPV1 and FPC ratios. Secondly, the machines themselves are made because you are supposed to feed in the weight and the demographic of the patient. Machines which are built abroad have to be incorporated with the algorithms for India-specific demographic, or the weight and height ratios to give us spit out the right results. So you have to be careful to just take the verbatim the findings that you get from a spirometry itself. Secondly, now once the clinician sits down to assess the voice, he generally uses the Gravas scale, as everybody knows. Now, Gravas, as we know, goes by the grade, roughness, breathiness, asthenia, and strain. These 5 points then we grade according to what we actually hear. And then over a period of time, we record them again and see whether there is improvement. The points you give them by 0 to 3, and that is pretty much straightforward. But sometimes what happens is that it is not very straightforward to grade them. Let us give you a sample. Now, this sample is pretty much straightforward. Now you can see it's grade 3. Now you can easily grade this as grade 3. Roughness is also 3. Breath is also 3. Asthenia is also 3. And obviously there's no strain, so I'd probably go 3, 3, 3, 0, and you'd probably be right. And that, well, see, I made a mistake here itself. I graded it 2 earlier on. But again, now the second one, it becomes very difficult. Now you can grade, you can label the grade as 1 or 2. The roughness also is 1 or 2, depending on your mood at that particular time. Sorry, not the mood. But yes, you can have confusions there. There you see, you can grade it any which way you can. But important thing is that you remain consistent when you're re-evaluating the patients as well. Now, my personal struggles is basically now if you have graded, you're doing 2 or 3 gradings at the same time. If you're graded 1, you're given 2 for a grade but then you listen to the second patient, then you find the first was even worse, that you want to go back and change that grade. So sometimes you have that dilemma. And second time, when you are reassessing the same patient after a certain time, do you want to listen to his before recording or not? Because then you become biased in grading the patient when you're doing on a follow-up visit. So I think you should avoid doing that. Just grade it as it is on the follow-up, and then you can go back and see what his initial grading that you have given to that person. Now, in stroboscopy itself, these are the parameters that you would actually look for, but there are some inherent pitfalls in stroboscopy themselves. The obvious ones are the anatomical ones and the difficulty in visualizing the larynx themselves, like the submucous fibrosis with a bulky tongue or an anterior larynx. Now, you can overcome them by using a flexible, but obviously the rigid gives us a better image. So this is not a completely should put you down, but these are the problems that you generally face. Now, discussing the parameters themselves. Now, the amplitude, as everybody knows, the amplitude is the excursion of 1/2 of the thickness of the vocal cord. But now remember, the vocal cord itself is about 7 to 9 millimeters thick. So then actually seeing whether it is going about 2 or 3 millimeters or is it lesser, it comes only with practice. So you could go wrong there. So avoid that. You actually have charts. Then you can plot it down to make things easier for you, but they don't. They really make it even more difficult. Now, I'll just give you an example of how you would actually look for an amplitude. If you're looking into this patient, without me saying much, you will appreciate the change in amplitude in this patient itself. Obviously, the patient has changed the pitch, and the amplitude has decreased. So again, you have to educate the patient to keep on vocalizing at a normal mid-range pitch to assess the amplitude, because that is going to affect your findings as well. Now, then when you're assessing periodicity, some of the stroboscopes don't have the locked mode, because you can't assess periodicity until you have a locked mode in the stroboscope. Sometimes I myself forget to switch on the locked mode to assess the periodicity. So these are small teething problems that you remember in hindsight that we should have done. Now the technique. Now again, the picture here shows a sulcus, but I think you can ignore that. But you could probably see that the left vocal cord is slightly lower than the right vocal cord. There's nothing wrong there. It's a faulty technique. I have a tendency to use my right hand and angle the telescope inside rather than putting it straight inside, and it probably give you an artifact as unequal vertical plane. But as long as you know what you're doing, I think you should keep that in mind while recording it. Now, actually assessing acoustic analysis of the voice itself, there are a lot of softwares that are available which will give you all the required thing to assess the acoustic parameters of the voice itself, like in fundamental frequency or the shimmer and the jitter. But the recording, whether that has been done correctly, because the quality of the mics makes a difference. The mic itself changes the fundamental frequency if you're not right. But if it does so, at least you let that be consistent also in all your recordings, but you should be aware that the matching of the frequency is not exactly as the frequency that you matched on your stroboscope. Secondly, the quality of recording equipment has to be good. Now, and sometimes when there is huge changes in pitch, obviously you won't be able to record this. So again, the ambient sound is going to make a big difference. I tend to use my audiology room to avoid the ambient noises, but these are the things that will affect the acoustic analysis score. Now, these things tend to be discouraging, but the whole point is to make you aware of them so you can factor in all these errors when you are assessing the patient. What is called as removing your zero error. So find out what is wrong in your, not wrong in your setup, what are the shortcomings of your particular setup, of your techniques, and then use them to compensate for your documentation. And at the end of the day, it doesn't matter if your grading is not same as somebody else's grading, but as long as you're consistent in yourself, that is more important. What is going to happen is you are the only person who's going to record to assess this patient after therapy, whether it's improved or whether he has worsened. So if your grading and your labeling has been consistent, it is the difference that is really going to make a difference, is what is more important. But as long as you are aware of these pitfalls, I think you will make your assessment much more accurate and much more reliable. Right. Thank you so much. And I thank the organizers once again for giving me an opportunity to address everybody of you. Jai Hind.
Good afternoon, everybody. So, just I thank to the organizers and Dr. Sanjay Subaya for giving me this opportunity to present in this occasion. This our one of the what is called, it is a Kumbh Mela of Phono Surgeons of India. That is a PSI, and I'm grateful that we are doing it by this method, that online. So I'm presenting with the role of video laryngoscopy versus video stroboscopy in hoarseness of voice, because we are doing video laryngoscopy in our OPD day-to-day basis, and video stroboscopy is a more refined form of it, and to do in different diagnoses. So hoarseness is the most common symptom of laryngeal pathologies. It is defined as a perceived rough, harsh, and breathy quality of the voice. Hoarseness is more prevalent in certain groups such as teachers and voice professionals. So video laryngoscopy, that is we are doing in the outpatient departments, and it is OPD procedure using 70-degree rigid endoscope. It has to the camera monitor for the evaluation of the oral cavity, oropharynx, and hypopharynx and larynx. And this is the setup we are doing in our OPD. We do a 70-degree endoscope with a camera system and the monitor. Then this is the procedure that the patient is the same we are doing in the OPD. Patient seated in the upright position in the OPD in a comfortable position in front of the examiner. 10% spray, you can spray it with the mouth, and in a non-dominant hand you use to retract the tongue, and with a gauze and pad, and you put the endoscopy slowly and looking to the structures inside, so that a panoramic view of the superior view of the larynx can be obtained. And this is the method we are doing video laryngoscopy we are doing in our OPD. This is the method we are doing. So we get this type of picture, a simple picture. Sometimes you can record that picture, and we can identify the structure. Sometimes the pathology, which is a very quick and detail about in your OPD. So that is the criteria. These are the criteria has to be evaluated. That is a retromolar trigon, and you can see the any growth and pH and discoloration determinant. You can see the posterior pillar, any congestion and discoloration. You can see the lingual tonsil. You can see the posterior pharyngeal wall, whether it is edematous and granular or congested or not. You can see the epiglottis, glossoepiglottic fold, shape of the congestion, edema and cyst. You see the vallicula. You can see the epiglottic fold. You can see the erythenoid. That is the moment and fixation of the erythenoid. You can see the piriform fossa, false VF, any hypertrophy edema or true VF. Then vocal fold position, whether any paralysis or any problem. Then vocal fold movements, symmetrical paralysis. You can see by this. So what is the merits of video laryngoscopy? It is an OPD procedure, can be done quickly, and may be done with a local anesthesia or by a spray, can do a panoramic superior laryngeal view. Then indirect piriform fossa can be visualized, hyperpharynx can be appreciated. But these are the, you can do easily in the OPD. If you want to do a quick procedure, you can do in the OPD. But its limitations, it cannot be visualized the mucosal wave. You cannot visualize the mucosal. Small lesions may be missed, misdiagnosed, or in high resolution setup is not used. Then evaluation of the subglottic is limited. Cannot even differentiate between many lesions, that is cyst and polyp. So cannot evaluate the glottic opening, closure. So many things. There is a lot of, because there is a very basic. This is a basic machine. Then why we do a video stroboscopy? For that we use a video stroboscopy, which is relative speed of the vocal fold vibration is more than 100 cycles per second. We all know. We will not go detail about the physiology of the how it works. Just because I have to only differentiate between why we do a video stroboscopy and why do we video stroboscopy. In the events that occur, more than 5 frames per second will be perceived as a blur by the retina. So this is due to the persistence of the vision up to the 200 milliseconds after light exposure on the retina. By using stroboscopic light that illuminates the subject briefly, one can freeze the motion at the same time in that cycle to allow the retina sufficient time to process the image. So these are the indications to evaluate the glottic cycle or mucosal wave, normal study in the flexible or indirect laryngoscopy, differentiation of the vocal fold or glottic lesion, preoperative evaluation, because you need a good picture and you get a good information about the preoperative stages of a patient. Then you need equipment. You need a more sophisticated equipment, good setup like soundproof room, height adjustable sitting area, and a rigid and endoscope with a 70-degree endoscope. We can do a camera, high definition screen, recording software system, everything. So this is our setup of stroboscopy room. How we are putting a soundproof room, recording by computers and the 70-degree scope. So this is the same procedure. Patient is seated, the height adjustable table, explained the procedure, and maximum phonetic time, minimum maximum frequency of the voice is measured. You can put a local anesthesia. Equipment checked the scope for defogging. You can use a defogger. Then same thing, tongue is retracted using the gauze pad. The scope is put into, and vocal fold is visualized, and we use the strobo light, and we tell the patient to say the E, the reading and recorded and evaluated by the machine. So we are doing, this is the procedure we are doing in the soundproof room. Then this is the video stroboscopy. You can appreciate how the waves are seen, and this is a bilateral vocal vocal fold nodule. You can see the hourglass aperture. You can see the movement of the, you visualize the structure, you can see the movement of the vocal fold. Then now the criteria to be evaluated, you can see the MPT, maximum phonetic time. 3 trials are report-based score can be measured using the stopwatch. We use the average of the 3 times. Then we use this vocal fold edges of the vocal fold, whether there is any nodule, any cyst or anything we can see. Then you can see the mobility of the vocal fold, right vocal fold mobility, left vocal fold mobility, whether it is normal, it is reduced, it is absent, or cannot be judged. There are options are there. We can put it and we can diagnose it. Then we can use this that is a compression of the vocal cord, that is lateral compression, that is anteroposterior compression, and the sphincteric compression. Then you can see the regularity of the vocal cord. This can be calculated whether it is regular, intermittent, irregular, or it cannot be judged. The regularity of the movement of the bilateral vocal cord can be judged. Then the amplitude of the then the mucosal wave. What is the right vocal cord mucosal wave? What about the left vocal cord mucosal wave can be calculated. We evaluate individually these parameters, to get a report, a correct report of the how the position of the vocal cord, how the condition of the vocal cord can be. Then this is the gap, the anterior gap, posterior gap, the glottic closure. You can identify what is the glottic closure, what is the anterior closure, posterior gap, or there is a hourglass aperture, or what is there is a midline gap or chink, the spindle gap or irregular gap. So we know different type of gaps can be identified from the vocal cord. Then that is the phase symmetry, whether this degree to which the vocal cords move as a mirror opposite images on each other, that is a 180-degree phase difference. So phase symmetry can be calculated. That is whether this is a asymmetric or that is bilateral asymmetry, or that is unilateral, or there is a closure. So phase symmetry can be calculated. Then we calculate the level, on which level they vibrate. The same level, different level, or cannot be judged. And the phase closure, you can identify the phase closure, the relative duration of appearance of consecutive glottal cycles. So many minute things can be calculated from the stroboscopy. Phase closure, then non-vibrating portion of the vocal cord can be identified from the stroboscopy. Right vocal cord, what is the portion is non-vibrating? In the left vocal cord, what is the portion is non-vibrating? We can calculate it from this and using different softwares of this stroboscopy. Then these are the merits of the stroboscopy. Evaluation of the mucosal wave, glottic cycle, glottic closure can be evaluated preoperatively or for planning of the surgery. Can be differentiated between certain vocal pathologies such as nodule, cyst, and polyp. You can differentiate very well. You cannot do in video laryngoscopy, but you can do by video stroboscopy. You can define the nodule, cyst, and polyps. Early diagnosis of many vocal pathologies which may be missed on the indirect laryngoscopy methods. So then maximum phonetic time frequency evaluation is possible, which is aids to the certain diagnosis of the like a muscle tension dystonia, androphonia. You can diagnose different diseases also by calculating different type of parameters of the stroboscopy. These are some of the limitations. Require a separate room for setup, trained personnel. You need a trained personnel, two-dimensional representation of a three-dimensional process. You need a good setup and a costly machine for that. So difficult to see the medial glottal surface lesion by this. Then requires periodic and persistent phonation 3 to 5 for activation of the strobe, which may be absent in severe cases. Sometimes you may not get that, but you need a periodic phonation. Evaluation of observer based and hence subjective. Therefore, finding may be vary among different examiners, and sometimes so that we can do put a uniform report system to overcome that. We can do that. Then these are some of the references we are putting. So that's why I'm finishing my talk. Thanks management. Thanks the doctors, and long live APSI. Thank you.
Good afternoon, everyone. I am very honored to be part of PHONOCON 22 program. My sincere thanks to organizing committee for allowing me to speak in this invited session talk. So, management of vocal nodules. So, vocal nodules are very common benign laryngeal organic lesions. They are located mid-membranous. They are fairly symmetrical. And they are located at the site of maximum trauma, maximum contact. So they are usually due to the phonotrauma. Over the time, they convert from the lesions of first appear as vascular congestion and edema, then they become more fibrosis, fibronectin deposits, they become hard nodules also. There are different kinds of nodules from early to the hard nodules. So let us hear some voices, how they present to us. Usually husky hoarse, reedy voice, have shorter MPT.
1, 2, 3 mandiri par
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
E 7, 8, 9, 10, 11, 12, 13,
She is
14,
a little
15,
less affected
16,
than her.
17. Okay. Say your word, please.
Then there is another person who throughout the day she is okay, but towards the evening she does not feel well.
और गुस्सा होता है तो ऐसा फोर्स करके बोलना पड़ता है, आवाज़ भी ऐसा धीमी हो जाता है और थक जाता है दिन भर काम करके रात को, वो भी शाम को भी रात 9:30, 10 के बीच ऐसा एकदम लो हो जाता है.
Then another, this is in singers also, it's also known as singers nodules because singers commonly present with the nodules. So they complain of difficulty in singing higher notes. There is a voice break like that while they sing. So when we go for the investigation part, we go for the endoscopy first. So in stroboscopy, we can see the prominent nodules. Mucosal waves are little impeded or maybe normal also in very early nodules. And the hallmark feature of the hourglass adduction pattern, glottic closure pattern that we can see in the screen. So coming to proper treatment, so what is the goal of the treatment? Is the improved quality of voice of the patient. So first thing is counseling and explanation of the disease to the patient. So what is the disease actually, why it has happened? So etiology must be explained to the patient. It's because of the vocal abuse and misuse of the patient that a nodule has appeared. So it's very important for them to understand, even if it goes away with all the treatment or therapy or any other way, it will come back unless and until they correct their habits. So number one point, what I stress mostly about is following the vocal hygiene. Voice rest, avoid shouting, drinking good amount of water, avoid habitual throat clearing, then to control reflux and acidity issues that we'll talk about shortly, and to avoid singing over a background noise or talking, avoid whispering, use a confidential voice, to take steam inhalation instead of gargling, because most of the people have misconception about the nodules that they have either pharyngitis or tonsillitis that will go away with gargling. Rather, it causes more harm than being useful to the nodules. Other nasal allergic ailments should also be treated, and to stressful environment should be avoided to maintain a balanced diet, etc. The children need special mention also. They need behavioral management so that they reduce shouting and all, screaming, incessant talking, loud talking behavior. The parents needs to be counseled about that. And during puberty, there is stretching of the muscular membrane and changes in the vocal fold that also cures nodules. But in some children it's not cured, then voice therapy needs to be considered for them. So second part is most important, that is the voice therapy part. It's an effective treatment to improve quality of voice, even though the lesions may not completely resolve sometimes because of the changes in the base membrane zone. But our aim is to improve the quality of the voice for the patient. So voice therapy is actually tailor-made for each patient. So everybody needs a different voice therapy. basically to reduce the phonatory gap by reducing size of the nodules. That can be achieved, and also associated condition needs to be treated also. So these two are the patients I showed previously. The voice center
मेरे गले में थोड़ा
after voice
बोलने से
therapy.
तकलीफ है, पर अभी थोड़ा ठीक हो रही हूँ.
So symptomatically she is feeling much
पहले से
better.
बेहतर है. Okay.
She is the gym trainer.
1, 2, 3, 4, 5, 6, 7, 8, 9.
Her voice
10,
is better
11.
only 2 weeks of following vocal hygiene and voice therapy.
1.
So there is another category of patients who needs a special mention. Those are the singers. Singers have nodules, so they are known as also singers nodules. But the nodules may be very slight, but for them it's very problematic to reach the higher notes. So whether doing flexible stroboscopy is most helpful in those cases. She can sing well, as we see, but sometimes when reaching higher notes, she is finding it difficult. Very early nodules, but she has some technique issue also. As you can see, when she goes for the higher notes, then there is no elongation of the glottic aperture. And while singing also, we can observe her.
Start.
Sa re ga ma pa dha ni.
While singing the higher notes also, she maintains the same oral aperture, because she needs to open her mouth wide so that our voice becomes louder properly, because she is using a wrong technique. Maybe that is why she is suffering from the nodules. So these are small things, but that carries very importance for the singers. So we need to explain that to them. So there are some associated factors as muscle tension, dysphonia, laryngopharyngeal reflux that causes that may be a contributing factors to the nodule or may be associated with the nodules. So they needs to be treated medically as well as with the exercises for the muscle tension dysphonia, such as neck massage and prolonged phonation when it's done with the vocal nodule program. For laryngopharyngeal reflux, the patient has a chronic cough, irritation, then throat irritation, then throat clearing habits are there, and chronic inflammation of the larynx will be difficult to resolve the nodules completely. So then it needs to be treated medically, as well as the habit correction about the diet habits and all. There are many times there are psychological issues are also associated, because it's basically associated with personalities also, the nodule formation, so needs to be treated whenever it's applicable. So next question is surgery needed for the nodules? It's very rare, if correctly diagnosed, very rare to need a surgery for the nodules. Cochrane review also in 2012, it was inconclusive in comparing an effective treatment for vocal nodules, as there was less data to compare surgical and non-surgical modalities of treatment. But Beguinon et al. Documented that even after surgery, the voice therapy is needed to prevent recurrences. Sometimes the cysts with the contralateral fold hypertrophy, they may look like nodules. So follow-up is very important during the therapy session. If the patient is not getting well or not getting the proper voice, then we had a case like this where it looks like a nodule, but 2 weeks then down the therapy, then we can see there is only one-sided cyst. We can see that, and that was operated and she got well. So sometimes rare cases like this also present. In surgery, Dr. Sutloff mentioned that correct diagnosis cures more than 90% of the nodules, or they become asymptomatic by voice therapy alone. The surgery, I have taken picture from the book because I have never done or I have never seen in my institute to do surgery on the vocal nodules. So it should be excised with the sharp instrument rather than stripping mucosa, or by, in some books it's mentioned, to be done by flap elevations method. So to conclude my lecture, diagnosis with follow-up is very important to check on the patients how they are doing. And vocal hygiene and voice therapy are the mainstay of the treatment. Surgery is required in rare cases, and even after surgery is done, postoperative voice therapy is always needed to prevent recurrences. There are some newer modalities mentioned where steroid injections are given to the vocal nodules in office laryngeal procedures, but results of those are yet to be seen in near future. These are my references. Thank you so much. I hope I could highlight some of the salient features of vocal nodule.
The aging voice, frankly, is a topic which I started to get interested in when I started using injection laryngoplasty to treat patients. I realized that this was a subset of patients which would really respond well. And this is an example of having a tool and then finding the disorder. I'm Brigadier Rakesh Datta, right now posted in Lucknow, and I would like to just bring to you all some insights on the geriatric voice. I thank the organizers of PHONOCON 2022 who have, despite these challenging times, brought this conference together in an online format. I wish we could have met physically, but nevertheless, here we go. No talk today is complete without a mention and tribute to the legend who unfortunately is no longer with us. And I would like to dedicate this talk to the one and only Lata Mangeshkar. Well, the sad fact is that aging is inevitable, and all of us do have to age one or the other day. That brings us to a question. When do we really start aging? When is it peak time for humans and we start aging beyond that day? According to science, this varies depending on the task we are considering. For example, for muscle strength, we may start aging at the age of 25 and maybe math skills after 50. On an average, it's said that after the age of 30 is when we start to age, and that's probably for most of us here. Now, is this an important issue of having voice problems in the aged? Well, there are studies which do indicate that, and in Western literature, it is said that up to 10 to almost half of all people do have some amount of dysphonia, which does get associated with other factors as well, which are psychological as well. Because it's not only about changing voice, but also because you're not able to hear very well, in also a reduced cognition. Regarding India, we did have a small study of our own, in when much of my students did a thesis in urban Western Maharashtra in a population-based survey, and we found approximately 1 in 3 or 28.8% of the population below the age of 60 did have a self-rated dysphonia using aging voice index. So what really is happening? Let's have a closer look. We know the production of sound or voice goes through various phases of initiation, generation, phonation, resonation, and articulation. So let's look closer at the voice box per se and the voice vocal cords closely. And I'd like to highlight two parts. One is the lamina propria, which we all know is divided into superficial, intermediate, and deep layer. And this is particularly important for us to understand and revise at this stage, especially its extracellular components, which include elastin, which provides elasticity, collagen, which gives it rigidity, and hyaluronic acid, which provides viscosity. Now, these components keep changing with age, and this is influenced by age and gender. Here you can see how various of these molecules are laid out in various layers from superficial to deep in the lamina propria. The second part which I'd like to just revise is tissue which is there located in the anterior and the posterior half of the vocal cord called as the macula flava. Now this is often even identified when we are operating, and its role was largely unknown till recently when it's been speculated of being a dense area with rapidly dividing cells and probably speculated to be the stem cells of the lamina propria. So, what has all this got to do with aging? These two facts. So, let me start by saying that the structure of the vocal cord keeps changing as we age. So, that is important, and we'll understand its role. The macula flava is very immature at birth and gradually matures. And the capability of a child's vocal cord to regenerate is much more at that stage. The vocal ligament actually itself appears only at the age of 4, and these differential layers of lamina propria only by the 10th birthday. In fact, it's a single lamina propria at birth. In now contrasting it to the geriatric vocal cord, there is again a loss of differentiation of the layers of the lamina propria. The macula flava has degenerated. The hyaluronic acid has reduced drastically. There's an increase in the collagen, reduction in the elasticity of the cord by a reduction of elastin and the framework, and increased in fibrosis. You can see fibrotic tissue in the picture. This is a schematic diagram of the same thing where we can see that the elastin has reduced and the collagen has vastly increased. So over the years, what is happening is the lamina propria from one layer to 3 layers in the later age is becoming indistinct. There is an increased deposition of collagen, which makes it more rigid. The elasticity is reduced, and the elastin tissue is gradually reducing in old age. Same with the reticular framework. The fibroblasts and the other blasts, myofibroblasts, have increased, which lead to fibrosis with old age, and hyaluronic acid is reduced. Macula flava, as I said, is immature at birth and gradually in the elderly age also disappears. Looking to the other tissues around it, the laryngeal glands itself atrophy with age. And what does happen with age is reduced lubrication and mucociliary clearance, which is reduced, which may lead to a dryness in the throat as well, and which can also cause a bit of problems with age. Or the controller, the higher the cranial system which controls voice also has undergone by this time an age-related dementia. There's poor neuromuscular coordination, which may lead to a lot of disarticulation. There's tremors and Parkinson's. So it suffers a multiple hit. Same thing may happen because of the thorax, where there's a weakening of respiratory muscles, which alters the respiratory mechanics, and the person is not able to phonate in a very powerful way, and reduction in maximum phonation time. The larynx itself gets ossified. There's atrophy of the glands, which you mentioned. The muscles get atrophied. The joint, coracoarytenoid joint deteriorates, and there is definitely increased stiffness, which all leads to changes in pitch. The articulators and resonators, which are the pharyngeal muscles and the upper aerodigestive tract, also is changing. There is incoordination. There is atrophy of muscles and thinning of oral mucosa and decreased salivary gland function. We see there are multiple factors which are happening with age, which will affect the voice of the individual. So what does all this practically mean? Practically, what it translates to is a change in pitch with elderly people, a breathy voice, a weak voice. The voice is not very clear and there is some noise in the voice. There are variations in the voice and effectively leading to a poor quality of life because the people cannot communicate well. When a person comes with such a problem, generally we need to pay special attention to the social history of the person because communication is a social skill, along with a mental state examination, a neurological examination, and a respiratory examination, considering the fact that voice is multidimensional and not purely just a sound box production used vibration. It is mandatory to have a look at the larynx, and one of the reasons why we do so is not really for the press by larynx, but we want to rule out other conditions. We want to rule out a malignancy, we want to rule out a vocal cord palsy, and we do often see that the vocal folds are atrophic, then there is a phonatory gap. Now, this diagnosis is easy to make. However, with the stroboscopy, the accuracy increases drastically. And glottic insufficiency in a mucosal wave, that is when the person is continuously phonating, is its hallmark. There are aperiodic waves in between on stroboscopy again, and we should evaluate the larynx apart from this from a voice handicap index and an aging voice index, which has been recently described. Very important to also evaluate hearing and swallowing because these functions can also affect voice. A reduction in hearing can actually make a person want to speak louder and therefore get more dysphonic, and an inability to swallow saliva well or a dryness of throat can also cause strain in the voice per se. Acoustic analysis is not mandatory to make such diagnosis. However, if we were to do an analysis of such sounds, which we did in our study, we do find certain findings. Primarily in the maximum phonation time, the fundamental frequency, the harmonic to noise ratio, shimmer and jitter, and other aerodynamic measures. As I said, these are not used for decision making. So what do we measure? We measure fundamental frequency as a change in pitch. We do an MPT assessment, which is judging the breathy voice. The weak voice we can make out from aerodynamic phonatory parameters or even otherwise when we are clinically assessing. An increase in noise as determined by a harmonic to noise ratio, variations in voice, which are in technical terms shimmer and jitter, and a poor quality of life using a voice handicap index. This is a diagram which shows how the frequency as we age increases, both in males and females, and you can see in females it gradually comes down with age and then finally towards the end rises, whereas in the men it rises from the age of 40 onwards and 50s onwards we have higher pitch coming and men and women sounding pretty much the same. A very important fact I would like to highlight towards the end, and that is the phenomena of presbyphonia and comparing it with presbylarynges. Now, this is an interesting study which was done and has around 31 dysphonics and 26 non-dysphonics, all people who have come to the OPD for other various reasons, the age of more than 75. And the findings are practically the same. In fact, the only difference in dysphonics versus non-dysphonics was the VHI-10. So what it indicates is that presbylarynx is pretty common. The findings are pretty common. It's only when the person started developing symptoms or started noticing that or making finding a handicap because of that that it became a disease or it became a condition worth attending to. So there are multiple management options and we'll briefly mention them. And the first one, of course, is the most commonly which is done, that is conservative and medical. There is a surgical option, and many times it's important not to do anything and just reassure that the person who may have come just for a suspicion of malignancy doesn't land up with the surgery unnecessarily. So voice therapy is something which we often prescribe when we have nothing more concrete to offer. But definitely there are some vocal function exercises which have been devised only with elderly people in mind, like the voice function exercises or the Stemple exercises, the Lee Silverman voice treatment, and I'll leave you to browse the net to know more about them. There are a set of vocal tasks which increase the person's, it's like a physiotherapy, and which may increase the person's ability to phonate better. The medical management, here it's not a drug which can improve, but here we have to identify a drug which is causing a problem. So many drugs actually are causing some amount of dryness in the throat, and we need to identify them. It may be possible to alter that drug very well. Otherwise, definitely it's important to recognize that entity. There is some research about growth factors being injected as possible therapeutics to encourage the regeneration of the vocal cord, but that's more in experimental stage. There are surgical options, and they largely consist of changing the structure of the vocal cord. With age, you may have to do a framework surgery like a type 1 thyroplasty to sort of medialize the cord so that they actually beat in a better way, and there's a better mucosal wave and causes the MPT to improve. A more popular option and easily done option is to add bulk to this thin and atrophied cord using an injection laryngoplasty technique. Now, this is an OPD daycare procedure where you can inject a substance which is usually hyaluronic acid and like a tissue filler, and the only problem being the cost as well as the fact that we need to repeat it. And we have a series on geriatric patients with injection laryngoplasty, but I'll not try to cover that here. And it does give very remarkable results, and some people who can afford it are definitely very inclined to use this as a treatment option. And spending your valuable time to listen to this. Definitely, to summarize, it's something which is very common and we need to identify it more. But it is important to diagnose and not overtreat this condition, but at the same time, offer an alternate to situations where it warrants. Thank you very much. I am open to any questions which may follow. And I would again like to thank the organizers of PHONOCON for a wonderful conference and giving me this opportunity. Thank you.
Hello, good afternoon, everyone. I'm Dr. Vani Krishna Gupta, and my topic for today is an enigma called the sulcus vocalis. Now, before we get into the sulcus vocalis per se, I would like to discuss the various layers of the vocal fold, starting with the superficial most stratified squamous epithelium, which has its own basement membrane. Then comes the lamina propria. It's further divided into the superficial, intermittent, and deep lamina propria. Superficial is also known as Ranke space, and intermittent and deep together make up the vocal ligament. Then comes the vocalis muscle, which is the thyroarytenoid muscle. Now, sulcus vocalis is basically a linear invagination of this epithelium along with the mucosal edge of the vocal fold. Now, this invagination can be either up to the superficial lamina propria, up to the vocal ligament, or up to the vocalis muscle. The normal pliable vocal fold cover of the lamina propria is now replaced by the invaginated epithelium. These are always parallel to the free edge of the vocal fold and were first described in 1892 by Giacometti. Now, they are based on the etiology classified into two types, congenital and acquired. There are a few theories postulated for the congenital sulcus. One of them is the faulty genesis of the fourth and the sixth branchial arches. Other is the degeneration of the fibroblast in macula flavae. Macula flavae are basically epithelioid bodies which are present in the vocal fold. Now, these are progenitors of the lamina propria, which provides the fibroelastic layer of the vocal fold. When they are degenerative, there is invagination of the epithelium which happens, leading to a sulcus vocalis. Familiar occurrence is another theory postulated for the congenital sulci. These are usually deeper, and there's more loss of lamina propria and are typically single. Acquired sulcus occur due to chronic upper respiratory tract infection, repeated phonotrauma, rupture of a vocal fold cyst, or poor healing from a vocal fold hemorrhage. So this is a combination of repeated infections, repeated trauma to the vocal fold, and with a less or a slower amount of repair process done by the body. These are typically less shallow and are multiple in number. Here is a picture showing a congenital vocal fold sulcus and of a acquired one. As you can see, they are more shallow and multiple in number than the congenital one, which is deeper and singular in number. Coming to the classification of sulcus, there are various classifications which have been proposed over the years. First one was by Boschai et al. They classified sulcus by two types. Sulcus virgator corresponds to the atrophy of the mucosa covering the vocal ligament. Sulcus vocalis, or the true sulcus, corresponds to an open epidermoid cyst with thickened epithelium. The bottom of the cystic pouch is here adherent to the vocal ligament. Nakayama proposed three types of sulci. Type 1 is the superficial one, which is confined to the superficial lamina propria. Type 2A is deep up to the vocal ligament, and type 2B is a pouch type sulcus. Ford et al. Classified them into three types. Type 1 is a physiological sulcus, which is usually seen as an incidental finding on a microlaryngoscopy. Type 2 is a full-length sulcus, where the depth is variable. Type 3 is a focal indentation, and it doesn't involve the entire length of the vocal fold. Pontus divided sulcus into four types. There's an occult sulcus, stria major and minor, based upon the distance between the two lips of the sulcus, and the sulcus pocket. Now, most of these classifications do not detail the length, the depth of the sulcus, because these are based upon the stroboscopy finding. So stroboscopy is not the best modality. It doesn't help us determine the length, the breadth, the depth, and the number of sulci. So as the length and the depth of sulci is inversely proportional to the voice outcome after the procedure or surgery or vocal speech therapy, we need to know more about the sulcus. And hence a new classification has been proposed by Nerurkar et al. This has been published in 2020 in the International Journal of Phonosurgery and Laryngology. Now here sulcus are divided into 6 types. So type A, B, C are basically sulcus, which the length of which is more than 50% the length of the membranous vocal fold, where the depth of invagination is up to the superficial lamina propria, up to the vocal ligament, and up to the muscle. Type D, E, and F are basically focal pits, where the length of the sulcus is less than 50% of the length of the membranous vocal fold. The depth is up to the superficial lamina propria, up to the ligament, and up to the muscle in type F. Now, in this study conducted, type A was the commonest sulcus seen and was commonly associated with phonotraumatic lesions as well. Now, this classification tells us about the depth of the sulcus, the length, the number of sulcus, associated lesions, and associated lesions within the sulcus as well, such as keratin and cysts and polyps, or an association with a mucosal bridge. Now, clinically, the symptoms correlate with the depth. The more the depth of invagination, worse are the symptoms, and worse is the prognosis of treatment. Physiological sulcus patients usually come with a normal voice. These are more of an incidental finding. The mucosal wave on a strobe is normal, and there's no phonatory gap. Shallow sulcus patients usually come with a rough and a breathy voice. They complain of vocal fatigue. The phonatory gap is usually less than 3 millimeters. The amplitude of mucosal wave is reduced in this, and there could be aperiodicity and asymmetry seen as well. Deep sulci are extremely breathy and hoarse voice. It can be high-pitched as well. There's air hunger and vocal fatigue because of the phonatory gap, typically more than 3 millimeters. This is a preoperative strobe of a sulcus, where we can hear the high-pitched voice of the patient. We can see multiple shallow sulci bilaterally. You can see an asymmetric phonatory gap in the vocal folds. These are the preoperative stroboscopy of a focal pit on the right side as seen in abduction and an asymmetric phonatory gap seen during adduction. Now, the mainstay management of sulcus is voice therapy. The reason being the post-operative results are still unpredictable. So if patients do opt for surgery, then a preoperative counseling regarding the unpredictable prognosis is really important. And after the surgery, there's a prolonged period where voice therapy has to be taken by the patient. Now, the aims of surgery are, one is addressing the deficit in the lamina propria. Now, this is at the level of epithelium or at the level of superficial lamina propria. At the epithelial level, the surgery is described as sulcusectomy, where the epithelium is incised on both the edges and it's just removed. The sliding down technique, elevation and redraping, and excision and suturing. Now, in excision and suturing, incisions are made on either sides of the sulcus. The submucosal flaps are released and the sulcus is excised. Now, both these flaps are sutured to each other, as seen in the diagram. Coming to Pontes and Bellows slicing mucosal technique and the laser-assisted release of sulcus. Now, in Pontes technique, a 1 millimeter gap is given between the epithelium and the superficial lip of the sulcus. The incision is given and the epithelium is lifted without touching the vocal ligament. Now, perpendicular cuts are made from this epithelium. These cuts are not of equal length. The whole principle of this surgery is to interrupt the fibrotic and tension lines of the sulcus so as to yield a free mucosal vibration edge. Now, this principle is very similar to what we use for a scar contracture release surgery. Laser-assisted sulcus release is based on two techniques: the sliding mucosal slicing technique of mucosa by Pontes and the principle of radial incisions that we give in subglottic stenosis surgeries. Here, multiple but complete epithelial lesions are made on the epithelium of the medial and lateral lip of the sulcus or the focal pit. The aim is to break the fibrous bands and to release the tension to flatten the sulcus and allow normal epithelium to grow on the raw edges. Over here, we see a surgical demonstration of LASR. The sulci are first palpated. The depth, length, and the number is estimated. Infiltration is given just lateral to the sulcus. Now, using a CO2 laser in scanning mode with an acute plate length of 0.3 to 0.5, depth of 1, that is 250 microns, incisions are made at 90 degrees to the lip of the sulcus. Distance between two incisions is around 0.3 to 0.5 mm. Now, we ensure that we leave mucosa over the anterior commissure so as to avoid webbing. Secondary epithelialization happens in such a way that by the end of the repair, there is no groove left between the two lips anymore, and the aim is to flatten out the surface. Coming to the SLP augmentation surgeries, fat injection, fat implantation, and autologous temporalis fascia implantation are few of the surgeries which have been done. These are pictures of fat injection. We can see that infiltration is done just lateral to the sulcus. Fat is now injected. The excess fat over the epithelium is wiped off by a cotton pledget. And this is how the picture looks after the surgery. Coming to fat implantation, incision is made just lateral to the lip of the sulcus. Submucosal flap is elevated. A pocket is created for flat implantation. A suture is placed before we place the fat graft. The fat is harvested from subcutaneous areas. These are cut into small pieces and they are washed with saline so as to remove the blood and excessive fatty acids from the fat. They are also soaked in insulin for 5 minutes. It's theorized that the insulin stabilizes the leukocyte cell membrane and improves the cell survival during the transplantation procedure. The suture is then done and the knot is placed outside the laryngoscope and slided inside. Coming to addressing the glottic insufficiency, if the phonatory gap is less than 3 millimeters, vocal fold augmentation procedures help. But if the gap is more than 3 millimeters, then a tharoplasty, medialization tharoplasty procedure helps reducing the glottic insufficiency. Excision of associated lesions such as polyps and cysts are also done, and mucosal bridges are addressed according to their breadth, whether they're complete or incomplete. So sulcus vocalis is a true enigma. It's a mysterious entity, the diagnosis of which is difficult. It's usually associated with lesions, so whether the voice outcome is going to be favorable or not is a difficult thing to predict. So it remains a true enigma, and I would like to thank the organizers for inviting me for this talk. Thank you.
Hello everyone. Today I'll be talking about a very common problem, muscle tension dysphonia. Now this is a condition which over the years has confused us quite a bit. In fact, we've called it by many different names. But in 1983, Morrison defined it as dysphonia caused by increased muscle tension of the laryngeal and paralaryngeal musculature. And this most aptly defines or describes the pathophysiology. As ENT surgeons, whenever we think of dysphonia, we think of the usual suspects, a cyst or a polyp. Sometimes when we find a small nodule, we will refer the patient for speech and language pathologists. But usually we know why we are referring patients for therapy. But whenever we find a normal looking larynx like this, we're quick to ask the question, is this functional? The answer is usually no. Purely functional dysphonia is very, very uncommon. So today what we'll discuss is what exactly is MTD and how does it occur? As people who will see it first, what is the real role of an ENT surgeon? How do we do therapy? What's the principles of management? And some of the newer techniques of managing for resistant cases. Now, more than 10% of all dysphonia referrals are due to some form of MTD. It's way more common in females, and often patients have a higher duration of dysphonia. Primary MTD means absence of any structural or neurological laryngeal abnormality, which can coexist with an increased muscle tension. And when the muscle tension is compensatory as a reaction to some laryngeal underlying pathologies, such as post-infectious adaptations, post-laryngeal reflux, or even secondary to a small nodule or a polyp, we call it secondary MTD. Now, how do we know how to assess a patient? That's fairly straightforward: history, assessment of voice, etc., etc. But invariably, we become very partial to some specific types of assessments. We often overlook the history and definitely often overlook the neck examination when we have dysphonia. And the most important part that is often missed is assessing the patient's body language and personality, which can give us a clue into their vocal habits. Now, there's often a confusing spectrum of symptoms, and that's because there can be many coexisting conditions. Now, primary or secondary muscle tension can not only give rise to dysphonia, but often it can also give rise to chronic cough, globus sensation, and even dysphagia. And this again can confuse us. So whenever we come across a patient on a neck examination, we should first look for any telltale signs, such as any deviation of the neck, constant tension over the face, the position of the larynx if it's very high up. All of these could be small clues. Often we find a mismatch between the voice that we hear from the patient and the laryngoscopic findings. And if you've done an objective voice analysis, we can find a lot of changes on the jitter, the shimmer, etc. And all of this can be confusing. But it's largely our endoscopic findings on which we depend on. And as clinicians, this is where we will either hit or miss some important findings. In fact, most of our classifications of muscle tension dysphonia are based on laryngoscopy. The Morrison and Ramage classification, which is widely used, is 1 to 5. Number 1 being a posterior glottic gap, number 2 being a glottic compression, which could either be just at the true glottis or at the true and false glottis as well. Type 3 is when we have an anterior-posterior compression. Type 4 is when we have a mildly incomplete adduction with or without a little bit of ventricular phonation. And type 5 is slightly different. Here we get a spindle-shaped gap, and this is often associated with either a pressed bilarynges or with certain neurological conditions of the larynx, such as Parkinson's disease. But often there is confusion, and a lot of studies suggest that plain laryngoscopy may not be the solution. That said, we should look for conditions such as a posterior glottic gap or normal mobility with an incomplete adduction, or sometimes when we find a severe supraglottic squeeze, we should be thinking of muscle tension dysphonia. Now, when we examine the neck, the most important part is a circumlaryngeal palpation. And here we look for a local tenderness, we look for a little bit of laryngeal stiffness over a particular specific point, such as the hyoid bone, the thyroid cartilage, etc., and over some of the straps. And although the amount of digital pressure we should apply is defined as just enough to blanch the nail bed, it can be a little difficult to standardize, and it will come only after we do it at regular intervals. Now, how do we treat patients of MTD? Well, it's a combination of two things: an indirect approach where we are trying to change to healthy vocal habits, and a direct approach, which is a combination of therapies which are used to manipulate the position of the larynx as well as modify the muscle tension. Now, the indirect approach is fairly straightforward. Counsel the patient, educate the patient, decrease the stress levels, identify abnormal behaviors, etc. But one part of the direct method, which is very important, is a manual circumlaryngeal palpation technique. Now, this is the principle of this way of treating is to apply pressure with a circular motion over some key areas, such as the major horns of the hyoid bone, the thyroid space, etc. Now, here, what we're trying to do is decrease muscle tension as well as the hyperfunction. Now, we also do various reposturing techniques, such as in this scenario where one of our patients is being palpated, and then we're doing it step by step. So the first step is to localize or locate the site of tension. The second is to progressively apply a little bit of pressure over the neck. And then we ask the patient to vocalize first simply and then in a more complex fashion. There are certain other laryngeal reposturing techniques, and this is based on the location of the muscle tension. So you have a pushback maneuver, pull down maneuver, in which we fraction the larynx downwards. And there's a laryngeal reposturing maneuver where we push medially and inferiorly. All this is fine, but how do we know that the patient is benefiting? Well, obviously, if there is an improved voice quality or the neck pain is decreased, then that shows improvement. But physically, we can examine such patients. We should look for the location of the larynx. It may actually descend. The tension over the neck may be decreased. But it's also important while we're doing these kind of therapies that the patient is motivated, engaged, and decrease any underlying conditions such as treating the anxiety. Unfortunately, more than 50% of patients relapse after 3 to 6 months of therapy. And fortunately, this is often partial, and often it can also be self-limiting. But it's important to know that this can happen so that we can address it. Now, if you ask any good laryngologist, they will always tell you that it's important to not only interact with speech therapists, but also understand therapy as to what the principles are. It's important to improve the strength and muscular coordination of the larynx, do various warm-up and stretching exercises of the neck. But resonant voice therapy is something which is frequently used. And here what we do is we try to phonate through a narrow glottic passageway. For example, when we ask a patient to gently hum and palpate over the face and over the malar prominence, that's something that we can see. Similarly, straw phonation, wherein we are narrowing the passageway of the airway, but not at the glottis, but at the supraglottis. So straw therapy is again quite easy to do. And then the yawn sigh method, wherein we decrease the vocal hyperfunction, it allows us to get a more relaxed voice. Now, the general relaxation of the body and improving of posture is often neglected, and this can also change the general body language of the patient, anxiety levels, as well as the posture of the neck. Surgery. Now, is there really any role for surgery for MTD? Well, there is obviously role in patients with secondary MTD, but in primary MTD, only for refractory cases do we think about surgical intervention. There is definitely a role for botulinum toxin injections, but in patients who have very severe supraglottic hyperfunction, we can consider a coablator-assisted vocal fold ablation, wherein we are mainly working on the false cords. Some studies show that there's a significant advantage of OPD-based injection laryngoplasty, especially when we're looking at type 4 and type 5 MTD, where there is glottic incompetence as the primary finding. There is some role to suggest transcutaneous electrical nerve stimulation can be helpful, just as an adjunct, and especially when MTD is associated with severe neck strain. But largely, what exactly are we hoping to achieve? Now, the only way we can ensure good results is by spending long periods of time with our patients. We obviously want to see a change in the video laryngoscopic findings, but we also want to look for a decrease in the voice handicap index. We also should understand whether there is a real change in the quality of life, and we can use quality of life index scores as well. But what we also need to do is spend more and more time interacting with our speech language pathologists, get their perspective, because a lot of times we get lost and we stop paying attention to some of the subtle ways in which a speech language pathologist interacts with our patients. The bottom line is the management of MTD has to be a multidisciplinary approach. This is a common condition which is often ignored and many times underdiagnosed. Hopefully, we can change that. Thank you.
Good afternoon, everybody. I'm Dr. Mahima Luthra, and I'm an assistant professor in the Department of ENT at Himalayan Institute of Medical Sciences, Dehradun. And today I will be talking to you about differentiating vocal fold paresis and paralysis. Any neuromuscular or nerve abnormality causing partial impairment of vocal fold motor function is called vocal fold paresis. There is preservation of some degree of mobility in vocal fold paresis. 1 in every 6 new patients presenting to the laryngologist, or 15% of patients presenting to a laryngologist, are diagnosed as a case of vocal fold paresis. It remains an underdiagnosed condition due to its subtle and variable presenting symptoms and clinical signs. The diagnosis may be missed as being normal or misdiagnosed as reflux, globus, or muscle tension dysphonia. Whereas vocal fold paralysis has been conceptualized as an all or none phenomena leading to absence of motion of the vocal fold. This absence of motion results from complete lack of neural input. However, electrophysiological studies suggest that vocal fold paralysis is a heterogeneous clinical condition and is best considered as a continuum of neurogenic dysfunction encompassing partial or complete denervation and variable degrees and patterns of reinnervation. The etiology for both vocal fold paralysis and paresis are similar. It may be idiopathic, it may be post-inflammatory or post-viral, it may occur secondary to neoplasms such as that of the larynx, lung, or thyroid. There may be iatrogenic injury to the recurrent nerve post-thyroidectomy, where vocal fold paralysis or paresis may occur post-intubation. It may be seen in patients of cerebrovascular accident or those with transient ischemic attacks, patients of rheumatoid arthritis, patients who have undergone radiotherapy, Congenital causes such as hydrocephalus, Arnold-Chiari malformation, and neuromuscular disorders such as Parkinsonism, myasthenia gravis, Charcot-Marie-Tooth disease may also lead to vocal fold paralysis or paresis. The afferent neurological functions, which include chemical, temperature, touch, and pain sensation, are important for modulation of normal motor activity of the larynx. The glossopharyngeal nerve fibers to the vocal folds and surrounding structures are carried via the superior laryngeal nerve via the internal laryngeal nerve. The recurrent laryngeal nerve carries fibers responsible for sensation in the subglottis and trachea. The sympathetic chain also lends fibers for modulation of normal motor activity of the larynx. Completely perfect glottic function is carried out by the efferent motor system. This provides abduction, adduction, and stretching of the vocal folds to modulate vocalization, breathing, and subglottic pressure. The superior laryngeal nerve is responsible for the activity of the cricothyroid muscle. The major motor input to the intrinsic muscles is via the recurrent laryngeal nerve. Any defect in this neurological circuit will lead to functional deficit and therefore symptoms of vocal fold paralysis or paresis. The symptoms of vocal fold paresis present with hyperkinetic features, although it is a hypokinetic condition. The symptoms arise due to inadequate closure or glottal insufficiency. The symptoms may also arise from isolated sensory involvement or in addition to motor deficits. The patient may present with breathlessness while talking and may have air hunger. The voice of the patient may be breathy. This is due to glottic insufficiency. The patient may present with pain on talking. The voice may be strained. There may be throat pain, voice fatigue, and voice changes. This is due to hyperfunction as a compensatory mechanism or due to shearing trauma of muscle tension conditions. The patient may also present with clearing of throat, cough, globus sensation or dysphagia and pitch restriction, which is due to the involvement of the cricothyroid muscles, and these occur due to laryngeal neuropathies. Here is a video of a patient who presented to us with the complaints of foreign body sensation for the last 5 months. He, however, had no complaints of change in voice. On doing a laryngeal endoscopy, we saw that the patient had right vocal fold paresis. The signs of vocal fold paresis and paralysis as seen on laryngoscopy may be classified into static and dynamic. Static signs are signs which are seen when the vocal folds are not in motion and are similar for both vocal fold paresis and paralysis. And these include arytenoid prolapse or asymmetry, asymmetry of the vocal process, bowing of the vocal fold, false vocal fold hypertrophy, height difference, laxity of the vocal fold, length asymmetry, piriform sinus widening, shortening of the vocal fold, ventricular widening, and thinning or atrophy of the vocal fold. In this slide, we can see the static signs of vocal fold paralysis and paresis. In the first picture, we can see the left ventricular hypertrophy and ventricular hyperreduction in a case of right vocal fold paralysis. In the second picture, we can see bilateral ventricular hyperadduction as well as a phonatory gap on adduction. In the center picture is a case of left vocal fold paralysis where we can see the bowing as well as a phonatory gap on adduction in a case of left vocal fold paralysis. In this down bottom picture, we can see the arytenoid asymmetry and right ventricular hypertrophy as well as ventricular hyperadduction in a case of left vocal fold paralysis. In this picture, we can see apparent shortening as well as bowing of the left vocal fold as well as a dilatation of the left piriform fossa. Dynamic signs are signs which are seen during motion of the vocal folds. Other than decreased motion in vocal fold paresis and absent motion in vocal fold paralysis, the other dynamic signs that are seen are asymmetry of the mucosal wave, asymmetry of the vocal process, axis deviation, false fold hypertrophy, height difference, supraglottic squeeze, and phase lag or shift. This is a video of a vocal fold paresis case wherein we can see the arytenoid asymmetry and ventricular hyperreduction. This second video is a case of a left vocal fold paralysis where we can see the arytenoid prolapse, the immobility of the left vocal fold, and a phonatory gap. Kaufman and Belowski proposed that midfold collections of Rinke's edema or pseudocyst termed as podules are invariably a consequence of underlying paresis. These occur due to the increased shearing trauma from effortful glottic closure. It is recommended that these patients with such lesions undergo medialization procedures. In patients of vocal fold paresis, medialization procedures such as injection laryngoplasty have shown to improve the glottic closure index and may serve as a diagnostic procedure for vocal fold paresis. We at Bombay Hospital, under the guidance of Dr. Nupur Nerurkar, conducted a 4-year retrospective review of the presence and pattern of ventricular hyperreduction following unilateral vocal fold paralysis, paresis, and unilateral cordectomy. These were the findings of our study. We had a total of 130 patients of vocal fold paralysis, out of which 70 patients developed ventricular hyperreduction. Amongst the 70 patients who developed ventricular hyperreduction, 62 patients developed contralateral ventricular hyperreduction, whereas only 4 patients developed either ipsilateral ventricular hyperreduction or bilateral ventricular hyperreduction. In the vocal fold paresis group, we had 24 patients, out of which 15 patients developed ventricular hyperreduction. Out of these 15 patients, 12 patients developed contralateral ventricular hyperreduction. 1 patient had bilateral ventricular hyperreduction and 2 patients developed ipsilateral ventricular hyperreduction. Investigations for diagnosis of vocal fold paresis and paralysis include laryngoscopy, flexible video stroboscopy, and laryngeal EMG. Traditional evaluation of vocal fold motion differentiated absence of motion that was diagnosed as paralysis from presence of motion. A gross vocal fold hypomobility or glottic insufficiency is readily identified. Visual clues such as vocal fold bowing, axial tilt of the larynx, anterior positioning of the paretic arytenoid, or a tilt of the posterior larynx to the side of the paresis are seen. However, laryngoscopy does not allow for assessment of subtle mucosal wave changes in paretic vocal folds. Rigid endoscopy also inhibits rapid and repetitive vocalizations. The problem of altered laryngeal biomechanics by rigid laryngoscopy is overcome by flexible video laryngoscopy. Rapid and repetitive vocalizations and various pitches and vowel sounds can be assessed by flexible laryngoscopy. Rubin et al. Outlined 3 specific repetitive phonatory tasks, which included alternating a sniff with the E vowel repeatedly, or by repeating he, or asking the patient to say pataka repeatedly. These help to diagnose vocal fold paresis. Flexible video laryngostroboscopy, however, remains idle. In a survey of 58 fellowship-trained laryngologists, it was reported that 89% primarily diagnosed vocal fold paresis based on laryngoscopic or videostroboscopic findings. Findings such as asymmetric mucosal wave amplitudes and frequencies are assessed by videostroboscopy, which cannot be seen on simple laryngoscopy. It also helps in the detection of phase lag and phase shift. It helps in assessing the tone of the vocal fold, which is indicative of the regenerative potential and hence prognosis. In this video, we see a case of left vocal fold paralysis. We can also see the mucosal wave asymmetry, the difference in the amplitudes, and the phase lag. Laryngeal EMG, however, remains a gold standard for diagnosis of vocal fold paresis or paralysis. The parameters suggestive of neuropathy are decreased recruitment, increased motor unit action potential amplitude, and polyphasic motor unit action potential. This diagram shows a normal EMG above and an EMG with decreased recruitment, as is seen in vocal fold paresis or cases of neuropathies. The interpretation of laryngeal EMG: 86% patients suspected of having paresis on clinical examination have positive confirmation on laryngeal EMG. It also helps in predicting prognosis or course of neuropathy. On laryngeal EMG, the findings are divided into 5 classes. In class 1, the EMG findings are normal. However, if there is vocal fold immobility, it may be due to arytenoid fixation. In class 2, there is absent spontaneous activity. The motor unit morphology, there are multiple nascent polyphasic motor unit potentials. This is suggestive of re-innervation and hence a good prognosis. In class 3, the recruitment is reduced. There are giant motor unit potentials, which is suggestive of an old injury and therefore poor prognosis. In class 4, there is polyphasic motor unit potentials and the findings are equivocal. These are suggestive of degenerative neurological conditions such as amylotropic lateral sclerosis. In class 5, the recruitment is absent. There are fibrillations, which is suggestive of an ongoing acute neurological injury. The other investigations that may be done in cases of vocal fold paralysis and paresis is a computed tomography. Imaging of skull base, neck, and chest is recommended in search for a potential cause for nerve damage. In cases of unilateral vocal fold paresis, CT had a 0% positive rate for identifying the underlying cause, whereas the positive rate was 35 to 55% in cases of paralysis. Here is an axial cut showing the dilated pyriform sinus and a malrotated arytenoid in a case of vocal fold paralysis. So, however, now even when we do get a normal laryngoscopy or videostroboscopy, we must think of vocal fold paresis if there is presence of cardinal signs of paresis such as isolated ventricular hyperreduction, bowing of the vocal fold, arytenoid asymmetry, aperiodicity of the mucosal wave, lesions such as paresis podule or pseudocyst. Diagnosis of vocal fold paresis may be missed since the clinical signs are subtle. A possibility of diagnosis of vocal fold paresis should be kept in mind if the patient complains of vocal fatigue, difficulty in projecting, pain with speaking, or hoarseness. A careful systemic evaluation of the history followed by careful laryngoscopy and preferably laryngeal EMG will help confirm the diagnosis of vocal fold paresis. Thank you. Good afternoon, everybody. I'm Dr.
I would like to thank the organizers of PHONOCON 2022 for giving me this chance to speak on non-selective reinnervation in unilateral vocal fold palsy, why, when, and how. So any such reinnervation, what happens is there is new neural input to the vocal fold adductors, primarily the lateral cricoarytenoid and the thyroarytenoid muscle, so that there is some muscle tone. It will result in some muscle tone, which can prevent vocal fold bowing and atrophy in UVFP. So EMG study shows that there is some amount of active innervation that is present in this muscle, even if there is no evidence, videostroboscopic evidence of arytenoid movement. So it represents some residual reinnervation by the partial injury of the nerve or a spontaneous reinnervation. So in the reinnervation procedure, any existing innervation is sacrificed by dividing the RLN. And what we do is the new neuronal axons that happens after the surgery will exceed the number that was existing prior to the surgery. So in the history, Fraser was the first one who reported an ANSA hypoglossal RLN anastomosis in 1924. He described a case report of a successful voice restoration by utilization of this anastomosis. And 1960s witnessed lot of improvement in laryngeal innervation prompted by the laryngeal transplantation. Takenouchi and Ogura in 1967, they described this ANSA hypoglossal neuromuscular pedicle flap. Tucker also popularized and refined the technique, and together these three scientists actually launched the new era of a laryngeal reinnervation. Some anatomical points. RLN has no topographic orientation along its length until it's branching inside the larynx. Most of the laryngeal recurrent laryngeal nerve injuries happens proximal to this point. So while after an injury, when the nerve regrows, there is no, it grows in a very random pattern. That is, adductor fibers of the nerve can grow into an adductor muscle or abductor muscle. And the same happens with the abductor muscle also. But adductor fiber is more than 3 times more than abductor fibers. So there is approximately 75% chance of connecting to an adductor muscle, while an abductor fiber has only 25% chance of reaching posterior cricoarytenoid muscle. So why we do it? We all know that the condition in which the adductor fibers grow into the abductor tubule and reinnervating a posterior cricoarytenoid and an abductor fiber growing to the adductor muscle is called laryngeal synkinesis. So dividing the RLN for reinnervation eliminates synkinesis. And the second point is it is not physiologically possible to reinnervate an already innervated muscle, even if the innervation is suboptimal. And any new nerve that is anastomosed to the common trunk of RLN will send fibers into both adductor and abductor muscle, which is a desirable effect, because we want some tone of the posterior cricoarytenoid muscle also, because that serves to keep the arytenoid vertically onto the cricoarytenoid joint. If the posterior cricoarytenoid muscle is completely denervated, what happens is there is unopposed pull of the thyroarytenoid muscle, and there will be shifting of the arytenoid with the resulting inferior shift of the vocal process and resulting in dysphonia. And there is this 3:1 ratio of adductor-abductor fibers, which can create some tone in the vocal fold. So it drifts into a more medial position. And any nerve supply that is given to a paralyzed vocal fold achieves a median position with muscular tension and bulk similar to the non-impaired vocal fold. And answers vocalis being the most commonly used adductor nerve, which is 10%, which contains 10% adductor fibers. So it gives a resting tone to the reinnervated muscle, and it gives vocal fold bulk, tone, and tension to the reinnervated cord. And what we achieve by this is the vocal fold meeting perfectly meeting during phonation with a sufficient symmetry. And the efficiency of cough and swallowing function is also improved. The advantages of reinnervation over static technique was listed by Crumley. So it is possible to restore near normal or normal voice without synthetic material being placed inside the laryngeal framework. So it does not alter stiffness of the vocal fold, and it restores the bulk to the thyroarytenoid muscle. It improves vocal fold positioning due to muscular contraction of lateral cricoarytenoid, thyroarytenoid, interarytenoid, and posterior cricoarytenoid. It is reversible by nerve section, and it does not preclude includes static methods if it should fail, and it eliminates dysphonia due to synkinesis if present. So by reinnervation, it restores a viscoelastic geometry of the vocal fold, while the static procedure, they don't give that. And the disadvantages: the need for an intact donor nerve. The distal stump of the RLN must be identifiable. The cost of this procedure is more than a static procedure, and a several month delay is there before the reinnervation become effective. So we know that the goal of the procedure is to restore resting muscle tone to the fore intrinsic muscle, and thereby normal anatomic position is restored, that is of the arytenoid and vocal process, and thus the vocal posterior glottis. So the patient should be counseled before the procedure that the return of the motion of the affected vocal fold in abduction and adduction is neither intended nor achieved. Earlier days, the reinnervation were used in professional voice users, especially singers, and in children. In singers, the type 1 thyroplasty, it just improves the speaking voice only, not the singing voice. And in children, since it is a growing larynx, we cannot do any static procedure in them, and they will never tolerate local anesthesia. But nowadays, it has been changed. Any vocal fold, unilateral vocal fold motion impairment resulting from an RLN injury with a loss of bulk and tone, they are candidates for doing this procedure. And the contraindications are more than 70 years gives an unfavorable result, because the nerve regrowth is very slow in 70 years, and diabetes and the post radiation and other comorbidities also, the patient should be advised that there will be a very slow nerve growth or a suboptimal reinnervation. And the EMG should be used to find out electrical silence, because palsy of more than 2 years duration may not have a successful reinnervation. And injury at RLN insertion site was contraindication before, but still we can find out the RLN at the joint, or dislocating the joint, and with its dissecting the intralaryngeal course. The ideal donor nerve characteristics are the minimal donor site morbidity, and there should be a large number of axons with adequate length to perform neurography without the need for nerve graft, because during the vertical excursion of the larynx, it should not pull the anastomosis site too much. So extra 1 centimeter length should meet this requirement. And the nerve graft with the 2 neurography sites should be avoided, because some amount of axonal loss happens along the neurography sites because of scarring. Up to 50% of the axons can lose. And coming to each nerve, ANSA is the most commonly taken donor nerve with no donor site morbidity. It is long enough, and it innervates the strap muscles, and which acts as accessory respiratory muscles. And it's a small nerve, and only modest number of axons are present. And the hypoglossal, there are more axons than ANSA, but it has been used in facial reanimation procedures. So there is a donor site morbidity than the other 2 nerves, but it is acceptable. But there is a 3.5 to 4 centimeter of intact RLN stump should be there for the anastomosis. And the RLN itself become a donor nerve in some situation, like a clean transection of RLN during thyroidectomy and all. But we can do anastomosis with a significant risk of synkinesis. And more axons, there are more axons than ANSA, and no donor site morbidity. But when a segment of nerve is involved, only few millimeters can be resected. There is no extra length of the nerve. And coming to the surgery, it is performed under general anesthesia, because the patient has to lie still for the neural anastomosis. And some patients who cannot wait for 3 to 4 months for a nerve regrowth, they can undergo a temporary injection medialization procedure at the time of surgery, and a horizontal incision is made and with the neck extended as in thyroidectomy, and after raising the flap, the dissection is done along the strap muscles. The dissection is carried out in the anterior part of the sternocleidomastoid to expose the IJV, and the ANSA is dissected in its whole length. And the next important step is to find out the RLN stem. Here the anastomosis being done with the RLN stem, ANSA to RLN. So for a microanastomosis, we require a microscope or a loop with a 70 proline or a 90 nylon. We can do the microanastomosis. Interrupted sutures of 3 or 4 numbers is sufficient. If there is a scarring of the same side of the neck due to some injury, previous surgery, the opposite ANSA is harvested, and either it is taken through a tunnel in the behind the larynx or anterior to the larynx. And in the anastomosis site, we can wrap the site with a piece of fat which is harvested from beneath the skin. So it protects the anastomosis site as well as it acts as a stem cell progenitor. So it's a picture of the same. We had 14 cases over last 4 years, and with a good voice in all of the cases. Tone was present in all cases, and in a few cases, the bulk was absent. I would like to show some videos of unilateral vocal fold palsy. She is a case of unilateral vocal fold palsy, idiopathic, and the vocal fold is immobile and in abducted position. And she has restricted lung disease with a severe scoliosis. So we couldn't do arytenoid rotation for her because of the scoliosis. She cannot lie down for 2 hours like that. We can appreciate the extremely breathy voice. This is after surgery, immediate post-op. You can see still there is a posterior glottic gap with the arytenoid prolapse here. This is immediate surgery. This is 6 months after surgery. We can now appreciate that the arytenoid is stabilized now with a good approximation of the vocal fold with the return of the tone and bulk. This is her voice post-op.
1, 2, 3, 4, 5, 6, 7, 8, 9.
This is another unique case. She had a left vocal cord paresis. You can see the video. Voice and MBD. This is her. You can see there is atrophy of the left vocal fold with the anterior glottic gap. This is the immediate post-op video. We did a fat injection laryngoplasty along with the highly selective reinnervation, that is answer to thyroarytenoid muscle. This is the immediate post-op. We can still see the fat in the left vocal cord, but the glottic gap is still present. This is 6 months post-op. We can say that there is good tone and vocal fold meets during phonation, and the bulk is also regained. She was a singer and she couldn't sing for 2 years, and she is so happy that she can sing again. That is about reinnervation. These are my references. Thank you.
Good afternoon, chairpersons and ladies and gentlemen. The present topic today, I'm going to discuss on the recurrent respiratory papillomatosis and mainly concentrating on the adjuvant treatment of recurrent respiratory papillomatosis. As all of you know, that I am Dr. Murthy, BSN Murthy from Vijayawada. I am the Professor of ENT and also the principal of the Penamina Siddhartha Institute of Medical Sciences. I am also the past president of the Association of Phonosurgeons of India. The recurrent respiratory papillomatosis is one of the lesions we used to see more commonly earlier days, but of late we have not been seeing that many cases. But still, it's a major problem and a major cause for morbidity and mortality in children. Earlier, we used to see that children die, children undergoing multiple procedures, but of late we have been not seeing that sort of a thing thanks to several technological advances which have taken place. As history takes back, the Morel McKenzie, the famous laryngologist, and Chevalier Jackson, all these people have done so much work on laryngeal papillomatosis, but major issue of human papilloma virus, which was demonstrated in laryngeal papillomas in 1982. That changed the whole concept of treatment modalities. It's one of the most common benign neoplasms seen in children, and earlier it used to be called as laryngeal papillomatosis. We used to call it the juvenile laryngeal papillomatosis because most commonly it is used to be seen only in children. Now we see also sometimes see in adults, and morbidity is mainly because of respiratory obstruction at the level of the larynx. As you can see the picture, you can see the large masses, but at the same time, most of these children do have an airway and they do breathe along through that. This viral etiology has been described in the recent past in 1982, and after that, the treatment modalities have been changed. Basically, we see two forms of juvenile nasopharyngeal fibroma, juvenile laryngeal papillomatosis, that is, and adult papillomatosis. The adult papillomatosis are more commonly to be the malignant transformation is more commonly seen in adults rather than in children. So basically, when you come to the etiological factors, the most common thing is human papilloma virus is a DNA virus, and this virus has got several types, and some of the types are associated with the HPV, with the juvenile papillomatosis. Because the papillomas occur not only in one area of larynx alone, it occurs in the entire respiratory tract, including the trachea, bronchi. It is then named as respiratory papillomatosis, and the most common feature of this is the recurrence and multiple surgeries. So the name has been changed to recurrent respiratory papillomatosis. The second important point is along with the HPV virus and infective agent, he also has got a post-immune response. So these immune responses also are very much important because even sometimes the lesion may be extensive even after reduced antigen expression. So basically the human response and also the infective agent, the virus, both can cause the lesion. So it can be present at birth or it can slowly present after the birth after 4 to 6 months or after 10 to 12 years. These are all things, and it is supposed to be a self-limiting disease, and after adolescence, the lesion slowly starts coming down. So there was the thought that there can be an hormonal imbalance also on the is responsible for this. So it can be an activation of a latent virus acquired at the birth. How do we actually? Takes about 19 to 35 years longer period than the pulmonary lesions. Now coming to the surgical modalities, coming to the treatment modalities, the surgical treatment is the most important modality of treatment. It is usually a microlaryngeal surgery with cold steel, laser, carbon dioxide laser, or some other KTP laser, NDAG laser, whatever lasers you can use. And then also now the new thing is coming up with the micro debriders. But unfortunately, any remnant left over can cause recurrences. And problem with any surgical debridements is the recurrences. There are children who underwent more than 20 procedures, 25 procedures, and 30 procedures. And that's the reason why there is a need for an adjuvant treatment. There is a need for the adjuvant treatment. So I just want to brief you of what are the available modalities of adjuvant treatment available for the recurrent respiratory papillomatosis. One of the commonest drugs being used is Cidofovir. Way back in 1999, it is what started working, started testing, and American Academy of Pediatric Otolaryngologists also recommend this. This is almost now more than 10% of the patients are receiving intralesional Cidofovir. These are the antiviral drugs. This is in addition to surgery. That's the reason why we call it as adjuvant surgery. Now, how do we decide on the outcome? The outcome decision is the recurrence may not be completely stopped, but at least the recurrences are delayed. That means the surgical procedures are delayed, and the time gap between two surgical procedures is increasing. That is how we look at the outcome of this disease, outcome of this adjuvant treatment. Cidofovir it's actually a cytosine nucleoside analog. It works on the inhibits for the polymerization reactions. Effect lasts for about for days to weeks, but we are specific HPV lesions subtypes is not again, we are not again very sure. Unfortunately, it is not recommended for the FDA has not recommended it for the RRP. Nephrotoxicity has been seen, and a few cases of malignant transformation also are seen after cetapavir. So antiviral agents are being used, but the evidence is not very high. Then we have the other drugs. There are about 57% of the patients have a complete relapse, that complete resolution. About 35% has got a partial response, and 8% patients have got no response at all. So it makes it a drug which can be relied upon, but unfortunately we don't have any placebo-controlled or double-blind studies, randomized studies. The next drug which is being commonly used is acyclovir. It is also an antiviral. We have been hearing so much of acyclovir in COVID and other reasons like even facial palsy. We have been using this drug. Now we are not using this much of this thing. It is disease-free time range is very less. You can't really, true efficacy can't be determined due to lack of again controlled studies. So it's basically may not act on the HPV, but it usually acts on the other co-infectors like HSV, Epstein-Barr virus or cytomegalovirus. These viruses are affected. Another drug now also being used is ribavirin. Again, one case series and one case report of 5 patients. Toxicity is there, headache and fatigue are commonly seen. Again, we are not very sure how far this works. Interferons have been used extensively. It actually because it binds to the specific membrane receptors which are altering the cell membrane, and they are anti-proliferative, antiviral. So the biggest study was a multi-center control study of 123 patients, which demonstrated a decrease in the disease progression of 1 to 6 months. But effect is not sustained. There is one thing important is that even the adjuvant treatment has to be repeated again and again. Another important thing is very commonly available Go Green. Most often this indole 3 carbinol, this is available in vegetables, that is mainly vegetables like broccoli, cabbage. These vegetables do abundantly contain this indole 3 carbinol, and it affects the growth and viral modulation on estrogen metabolism, because this also has an effect, because we also discussed that these lesions are sometimes self-limiting and disappear after the puberty or adolescence, and probably there is some sort of a response. Again, not very big studies, it's small studies of 49 patients, and that is available for long term, and only 33% responders, 30% partial responders, and 36% non-responders. Mumps vaccine also has been tried, and again about 29 patients and children and 20 adults. Mechanism is unclear, but still has been used. The most common experience most of us in Indians have got is Tuza. Tuza is a drug which is a homeopathic medicine, which is very commonly used for the warts on the foot, on the feet. This has been used extensively by most of the Indian laryngologists and Indian surgeons who operate on recurrent respiratory papillomatosis. There are no controlled randomized studies. It is only a surgeon-based surgeon-based remarks saying that Tuza works, but there are no proof and tests. Reflex and esophageal reflex and laryngopharyngeal reflex is supposed to exacerbate recurrent respiratory papillomatosis. So the control of extraesophageal reflex disease will have an effect on treatment of recurrent respiratory papillomatosis. So usually we start giving them proton pump inhibitors, because there is a conclusion that there is a link between these two, and you can as well see the response. You see the papillomas, you also see the posterior granular appearance of the posterior larynx in all these cases. Coming to the new frontiers coming up are some of the new drugs coming up are the HSP-E7. It is a recombinant fusion protein derived from the Mycobacterium bovis. This is again activities are not very known clinically because HPV 16 lesions also have got response to this HSP-E7. So this is one of the common new drugs coming up, and we need to though again the studies are very small and small numbers are small. These are all the drugs which are to be kept in mind. So this again another new drug coming up is again a recombinant anti-VEGF factor is bevacizumab. These are all the monoclonal antibodies, humanized monoclonal antibodies, very commonly being used for various diseases nowadays. So immunotherapy, a sort of immunotherapy also is now coming up in a recurrent respiratory papillomatosis. Again, celecoxib is again a selective non-steroidal anti-inflammatory drug. It is also being shown some efficacy in adjuvant therapy of respiratory papillomatosis. PD-1 inhibitors, like these are the new drugs coming up. These are all programmable cell death causers, proteins. These are supposed to be very effective in HPV-related head and neck squamous cell carcinomas. Most of them is a nasopharyngeal carcinoma. In those cases, this drug is effective. So it's also being now tried in cases of recurrent respiratory papillomatosis. Another drug which works on the epithelial growth factor is gefitinib. Again, these are all monoclonal antibodies which are effective on various cells. A few words about HPV vaccine. The HPV vaccine is being promoted, highly promoted by the obstetricians and gynecologists to prevent the cervical cancers and cervical papillomas. So there is a lot of controversy on the HPV vaccine. Who needs to be taken? Only women, girls have to be given, or boys? Both boys and girls have to be given. At what age it should be given? At the age of adolescence or what? So there is a lot of controversy, and there is a lot of controversy which that itself cause the uh, problems of cervical cancer. So that also needs to be kept in mind. So basically, a relatively rare problem, but it is problem is with poor quality of life, multiple treatments. Earlier days, we used to see number of patients, number of children with tracheostomy. Now we are not seeing tracheostomies. Tracheostomy has been now downgraded, and hardly any patient any child or adult undergoes a tracheostomy for a papilloma virus. With the advances in anesthesia and training of anesthesiologists, intubation in a papilloma patients is becoming easier, and emergency procedures are taken over by and so bypassing the larynx and doing a tracheostomy is not indicated nowadays. The probable indication, the only indication is to isolate the larynx from the lower respiratory tract to prevent the laryngeal papilloma going down into the trachea and bronchi. Probably the tracheostomy is needed. Otherwise, the role of tracheostomy is gone. The only thing is number of frequency of surgical excisions, cost effectiveness, and if the lasers are being used, the amount of fibrosis, amount of destruction of the so smooth and the soft tissues of larynx in a small child. These are all the things, various things which contribute to the morbidity and the mortality of the patient. At least the mortality has come down. Now, there's still so much to uncover regarding the HPV. The surgical treatment is the mainstay of treatment or the gold standard of the gold standard treatment with either cold seal or with powered instruments, macrodebriders, lasers, and vibrators, and an adjuvant therapy to prevent the recurrence is still the important part of the treatment of laryngeal papillomatosis. These are my references, and thank you very much for your kind attention.
Greetings, everyone. Thank you to the organizers for allowing me to share this platform, and I will be talking to you about how to avoid complications in microlaryngeal surgery. Unlike most open head and neck surgery, microlaryngeal surgery has some unique challenges in that we are operating in a very limited space with restricted maneuverability of instruments. The assistant can't really assist us during surgery, and you're dealing with very tiny microscopic disease, a few millimeters in length. One needs to be ambidextrous often, especially if you're using your left hand to operate the laser micromanipulator. And the laser microscope or the video laryngoscopy system means there is a lot of cumbersome equipment between you and the patient. And you're often relying on the equipment to be of the highest quality to give you good results. The incidence of complications, although reported to be 10 to 75%, is more often than not very minor injury to the oral cavity or oropharyngeal mucosa, and major complications, although potentially disastrous, are thankfully very rare. So today I'll be talking about the complications under three heads: those related to anesthesia, those related to the equipments being used, and some specific procedure-related complications and how to avoid each of these. Anesthesia-related complications happen because anesthesia for MLS presents with some unique challenges. Sometimes you can have a difficult intubation right at the get-go because of a large glottic or supraglottic growth or extensive papillomatosis. And also if you're dealing with webs or compromised airway, anesthetist is already forewarned that all of these situations can begin with the patient not being able to get intubated. If you're using a laser for phonomicrosurgery, then that has some challenges in the way that the anesthetist has to use or work with decreased FiO2 levels. The suspension of the larynx itself is a stimulus for bradycardia and even sometimes arrhythmias. Post-extubation laryngospasm is something which all anesthetists will tell you is a very difficult to deal with complications. Whether you're working with the apnea technique or the venturi technique, or like most of us using a small size tube for a large normal adult, all of these have potential complications of hypoxia and hypercarbia. So how do you avoid these? Well, it is useful to have an anesthesia team that is well versed with microlaryngeal surgery and compromised airway cases. One must always use laser safe tubes to avoid laser related complications. Be ready for a tracheostomy, especially when you're dealing with, again, compromised airway situations. As ENT surgeons, we are always ready to do a tracheostomy, and that gives a good comfort to the anesthetist. But if the anesthetist is most comfortable giving you an apnea technique in between, then one has to be prepared to do that as well. We are literally working in the same field. We are cooperating, so one must cooperate. Some equipment-related complications now. The most common is mechanical trauma in the form of injury to the oral cavity mucosa, floor of the mouth, tonsillar pillars, etc. And that too more on the right side because that's where our scope is inserted from. Dental trauma to the upper incisors, where our laryngoscope rests as a fulcrum, is especially a concern in patients who have implants or caps. Patients who have temporomandibular joint disorders can get aggravated. The problem can get aggravated because of the stress of the laryngoscopy. I just showed this picture to show a seemingly benign looking abrasion over the upper lip became a painful ulcer in the post-operative period. So although these injuries are minor, all care must be taken to avoid them. And one can be forewarned of a situation where you might have a struggle in inserting your scope and you might be using force, which can cause mechanical trauma. So always beware of such situations. Patient who has got unfavorable dentition, where you might not get a good fulcrum for your suspension laryngoscopy system, or it might give a lot of stress to the upper incisors, it's a good idea to use dental protectors. Lingual nerve anesthesia or tongue paresthesia is a more distressing complication and can last up to weeks. That happens because of the stretching of the nerves and the pressure of the scope itself, and especially if the surgery has gone on long, or if you have had to use a lot of force because of difficult exposure, then this can happen. So how do you avoid all of these complications? Wait for complete muscular relaxation and don't force your laryngoscope in. Twiddle your thumbs and allow the scope to glide in easily. Wait and bide your time. Insert the scope under good vision with good illumination. Whenever you are doing a laryngoscopy, you tend to look through the scope. So have an assistant keep an eye on the lips so that they are not getting trapped between the teeth and the laryngoscope. And if you are anticipating a difficult exposure or a patient who has got unfavorable dentition, always have this documented in your preoperative consent and make the patient aware of potential complications. Use an appropriate size scope. There is no one size fits all. One must have a variety of scopes available to handle any situation. And if the surgery goes on for a prolonged time, especially oncological resections, then it is a good idea to release the suspension in between. And if you're using a compression bandage, then loosen the bandage to minimize pressure. Avoid having the chest piece directly on the chest. We like to use this Mayo's trolley, which goes across the patient, and then the chest piece rests on it. The trolley is fixed to the bed, patient's operating table, so that the whole assembly can go up and down. And if you're using an anterior compression bandage, then use a thick cotton mop beneath it to avoid direct strangulation kind of pressure over the cricothyroid membrane. Now coming to laser-related complications, they could be in the form of thermal damage, laser fire, or carbon granuloma. Some amount of thermal damage, of course, is anticipated whenever you're using a laser because the tissue is subjected to extremely high temperature. But one can minimize thermal damage by choosing the appropriate type of laser. Whether you're working with a contact laser or a non-contact laser, all of these should be tailor-made to the type of situation that you're dealing with. Choose the correct indication. Just simply because you have a laser, don't use it for every unnecessarily when it does not need to be used. And one can, of course, modify all the settings on the laser machine. You can change the wattage you're working with, the pulse width, whether it is a continuous pulse or a ultra pulse or a super pulse. So the degree of wattage or the power that you use will depend upon how much vaporization or ablation happens. But carbonization depends upon the mode that you're using the laser with. Of course, continuous mode giving us more carbonization. So it's a better idea to work in a super pulse mode if possible. And the coagulation area, that is the unintentional thermal damage, depends upon the pulse length. That is the duration in which you have the laser on for. So this time on, time off can be modified so that the tissue is allowed to cool down between subsequent pulses of the laser, causing minimal dissipation to the surrounding area. One must have precise controlled movements. No inadvertent firing of the laser should occur. It's a good idea to have subepithelial infiltration done, which acts as a heat sink. Most of us are working with the CO2 laser, which is best absorbed by water. So that acts as a heat sink to prevent thermal damage to the deeper layers of the vocal folds. And mop the vocal folds to allow the tissue to cool down. Laser fire is the more dreaded but fortunately very rare complication, and that happens when the laser beam directly hits onto the endotracheal tube and spreads like a blowtorch throughout the airway. One must act within milliseconds, immediately remove the tube, disconnect it from the gas-enriched anesthesia circuit. The anesthetist in the meanwhile must concentrate on ventilating the patient and prepare for re-intubation. All of the laser complications can be avoided by taking appropriate care. Avoid inadvertent firing of the laser over the patient's eyes by protecting it with wet gauze. All OT personnel should wear protective eyewear. Always use laser-safe tubes. The double cuff Mallinckrodt tubes are very useful, and one of the cuff can be inflated with methylene blue so that if inadvertently the laser beam hits the cuff, the operative field is flooded with a blue color, giving you a warning that you are hitting the endotracheal tube. Work with decreased FiO2 levels and no nitrous. Whenever the laser is not being used, it must be put on the standby mode. A large subglottic patty under the vocal folds will prevent your endotracheal tube from inadvertent laser damage. And a suction for the laser plumes means that you are not working with an obscured vision and it is hitting the precise target. A bucket of water must be kept ready in the OT so that you can, in case of a laser fire, immediately extinguish it. And an indicator outside the OT warns a personnel entering the OT that there is a laser being used. Ultimately, it's a tool, so one must be careful how one uses it. Carbon granuloma is something which presents as a concern in the post-operative period and can happen when there is a granulomatous lesion developing at the operative site, especially when extensive resections like a type 3 or type 4 chordectomy have been done and poor patient-related, wound healing-related situations. This can be avoided by ensuring that at the end of the surgery, you have smooth margins and you should clean the the operative site to avoid any foreign material like char or fibrils from your patties, etc. I know Dr. Nupur likes to give this laryngeal wash, which is similar to the wash we give in endoscopic sinus surgery. Post-operatively, nebulization and managing of laryngopharyngeal reflux is also a good idea to avoid formation of granulomas. Whenever we are working with powered instrumentation, be careful to use them for very select indication. They are not for fine cutting. They are more for debulking or more like a Kashima chordotomy, where you are using a lot of posterior cord cutting, which can be done with the cobblator, etc. But always keep the cutting edge under vision. Some specific procedure-related complications. Whenever any microlaryngeal surgery is being performed, some amount of edema or slough, as you can see in this picture, of course is expected and should not be considered as a complication really. What is more troublesome is scarring. And scarring happens when there has been aberrant fibroblast proliferation, and especially when you have had a lot of loss of tissue, especially the SLP, and the cover then gets stuck onto the underlying layers and one loses the mucosal wave. Here you can see a small looking lesion, which was actually a recurrence of a papilloma, but because it had shown squamous cell carcinoma transformation, we had to do a sort of an extensive resection, giving rise to a significant scar and a gap, phonatory gap in the post-operative period. Web is something which is most difficult to manage post-operatively, so it is best to be avoided. That can happen when there are two opposing raw surfaces and again with extensive resections. So you can avoid all of these by following some principles intraoperatively and post-operatively. Always use principles of phonomicrosurgery, do the mini or the mini microflap technique, handle tissue with respect. You can always stage a resection, specifically when you're dealing with leukoplakia, etc. If it is a bilateral disease, one can deal with one side at a time and always come back to do the other side, opposite side, to avoid opposing raw surfaces. Post-operatively, when extensive resections have been done, one can plan for planned slough cleaning a week later to allow that the web does not form. And voice rest and humidification post-operatively again will allow smooth healing. Some specific complications could be when you're dealing with an injection laryngoplasty procedure and accidentally inject into the wrong plane, especially when you're using rigid material like calcium hydroxyapatite. So be very careful of where your injection material is going in. If there is extensive bilateral injection, it can cause airway compromise, but this is very rare, and giving the patient humidification, steroid injections, etc. can help tide over this situation. Whenever one is doing an arytenoidectomy or a Kashima chordotomy, you're always walking the thin line between a safe swallow and a good enough airway. So that has to be kept in mind. And when extensive endoscopic oncological resections, chondritis is a potential complication. Some general principles always to be remembered: always have good illumination, use a variety of scopes to handle any situation, have sharp and precise cutting instruments, clean the field at the end of your surgery. Always remember less is more, and patient selection and preoperative counseling is very important. Have a good post-operative protocol, especially when it comes to voice therapy, voice rest, etc. And know your limits. If you know you are unable to handle a particular situation, best not to enter into it. To err, of course, is human, so no matter what one does, one will have some complications sometime, but it's important not to repeat the same mistake. So I hope this has been useful to you, and I thank you very much. Greetings, everyone. Thank you to the organizers for allowing me to share this platform.
Good evening, one and all. Let me straight away go to my presentation on voice feminization surgery. The more appropriate terminology for transgender is gender dysphoria or gender incongruence, which is considered as a mismatch between a gender identity a person perceives and his biological gender. The prevalence is considered to be around 0.3 to 0.6% in adult population. According to the World Professional Association for Transgender Health, they have proposed particular criteria for sex reassignment surgery, and accordingly, it has to be certified by two mental health professionals. 12 months of hormonal treatment has to be taken, and the sex reassignment surgery, the SRS, is done by a multidisciplinary teamwork which includes a plastic surgeon, maxillofacial surgeon, gastroenterologist, urologist, and of course the laryngologist for the voice feminization. The facial feminization surgery and voice feminization surgery is considered the aesthetic surgery among the SRS. And this is our team at Renai Hospital involved in transgender health. Coming to the voice feminization, it could be a non-surgical approach or a surgical approach. The non-surgical initial voice therapy definitely has a role. The voice therapy focusing on increasing the fundamental frequency, changing the oral and pharyngeal resonance, and the behavior therapy focusing more on the intonation. And if the patient is not satisfied with the acquired voice after a voice therapy, then we proceed with a surgical modality. The surgical modality consists of a cosmetic procedure, the Adam's apple reduction, which is otherwise called the thyroid chondroplasty, where the acute thyroid angulation is contoured and smoothened out. So if the thyroid cartilage is ossified, usually we have to drill it out, and we make sure that only the upper half of the thyroid cartilage at the level of the midline is removed, and it is smoothened and contoured, and the acute angulation is thinned out, and a smoothing is done. And if the cartilage is very thin, we just can slice it with a surgical blade. And for this patient, it was very thin. The cartilage was so thin that I could just slice it off with a surgical blade. And coming to the next part, the voice feminization surgery. The usual male pitch would be around 90 to 130 hertz, and we need to change that from that pitch to around 180 to 230 hertz. And usually, the transgender who are they would be undergoing hormonal treatment, and it would be at a higher range of the male pitch it would be around 120 to 130 hertz, and we need to change it. And the surgical principles is based on string physics. We can either decrease the length of the vocal cord, the effective vibratory length of the vocal cord, decrease the mass of the vocal cord, or increase the tension of the vocal cord to attain a higher pitch. You can see here that the thicker string has a lower frequency and the thinner string has a higher frequency. And based on the factors which are modified, the surgical procedure can be a one-factor modification, two-factor modification, or three-factor modification. The surgical options available are type 4 thyroplasty, where we change the tension of the vocal cord. A cricothyroid approximation is done. Anterior glottoplasty, otherwise called the Wendler's glottoplasty, when the prescient mucosa is sutured. Laser assisted voice adjustment surgery, which decreases the mass of the vocal cord. Laser reduction glottoplasty also decreases the mass of the vocal cord. And feminizing laryngoplasty, which is a three-factor modification done externally. And vocal fold shortening with retro displacement of the anterior commissure, which is an endoscopic three-factor modification procedure. Coming to each procedure in detail. Type 4 thyroplasty is the most commonly done procedure. It's a one-factor modification where the tension of the vocal cord is increased by mimicking the action of the cricothyroid muscle, and we attain a cricothyroid approximation. The usual problem with the thyroplasty, type 4 thyroplasty, is that you can attain an immediate post-operate, you get a very good increase in pitch, but there would be a pitch drop in 1/3 of the cases later on. And another procedure is the anterior glottoplasty, where the effective vibration of the vocal cord is decreased by forming an anterior glottic web. It's a one-factor modification by decreasing the length of the vocal cord. And if this procedure is done on the laser and a suturing is done, then it's called a Wendler's glottoplasty. The laser assisted voice adjustment surgery. It's a one-factor modification by decreasing the mass of the vocal cord, where a superficial scarring is done over the superior surface of the vocal cord on both sides. But the disadvantage is that the required increase in pitch is not attained, and hence another technique, the laser reduction glottoplasty, a modification of the lava, has been proposed, where along with the mucosa epithelium, the vocalis muscle is also vaporized with the laser, and suturing is done. Recognizing laryngoplasty, three-factor modification by an external approach, which is popularized by Dr. James Thomas. The anterior part of the thyroid cartilage is excised. The anterior end of the vocal cord as well as the false cord is excised, and the vocal cord is stretched, and anterior commissure is reconstructed, and the thyroid cartilage is approximated with a plate and screw. The vocal fold shortening with retro displacement of the anterior commissure. It's an endoscopic procedure, and a three-factor modification is done here. Anterior part of the vocal cord, it's similar to the Wendler's glottoplasty, but the anterior end of the thyroarytenoid muscle is sutured to the thyroid inner perichondrium endoscopically, and it's attached at a lower region, at the subglottic region. Coming to our cases, we had total of 5 cases from March 2019 to November 2021, where we did an anterior glottoplasty with type 4 thyroplasty, that is a two-factor modification was done. Anterior glottoplasty, these were the surgical steps. Suspension laryngoscope was introduced. The larynx was visualized completely up to the anterior commissure. Infiltration was done. Mucosa was excised up to the anterior commissure, and the mucosa of both sides were freshened. The anterior 1/3 of the mucosa on both sides were excised. This is the surgical video. Suspension laryngoscope was introduced, and the vocal cords were visualized up to the anterior commissure. Infiltration was done on both sides. Actually, it's a violation of the usual surgical principles. We are excising a perfectly normally looking mucosa, and usually what we say is to not to disrupt the mucosa at the level of the anterior commissure on both sides, because webbing would be the rule. And here what we require is a webbing, and so what we do is we remove the mucosa on both sides of the anterior commissure and make sure that it's completely removed. We didn't go for a suturing of the mucosal lining, and we could attain, out of the 5 cases we did, 4 of them had a proper webbing was formed for 4 of them. Coming to the type 4 thyroplasty, as for any neck surgery, a midline neck incision, patient in supine position, neck extended, a midline neck incision at the level of the lower border of the thyroid cartilage, and between the lower border of the thyroid cartilage and cricoid cartilage in a skin crease. strap muscles were retracted, subplatysmal flaps were raised, strap muscles were retracted, and thyroid cartilage as well as the cricoid cartilage was skeletonized, and the suture was taken from the lower part of the cricoid cartilage through the thyroid cartilage, and at least we make sure that from the lower border at least 1/3 of the thyroid cartilage is covered, and we suture it up uh, with the proline, and we make sure that the knot is placed over a celastic bolster, and we attain an obliteration of the cricothyroid space. This is a surgical video. This procedure, the type 4 thyroplasty, is usually done under general anesthesia, and the patient can be intubated. And this is the procedure, usual supine position with neck extension, and the midline neck incision at the inner skin crease at the level of thyroid cartilage, lower part of the thyroid cartilage or over the cricoid cartilage, and we raise the subplatysmal flaps on both sides and retract the separate the strap muscles so that we can visualize the mid part of the thyroid cartilage as well as the cricoid cartilage, and the cricothyroid muscle is delineated completely. And we make sure that the inferior border of the cricoid cartilage is delineated well so that we can take the sutures through the space. Sometimes if the thyroid cartilage is ossified, we may have to go for a drilling a hole for taking out the sutures, and usually we take 4 sutures, 2 on both sides of the both sides of the thyroid cartilage, and we make sure that at least 5 mm distance is kept from the midline to the medial sutures, and the sutures are placed over a elastic bolster so that there won't be any give away of the thyroid cartilage. Sutures are taken. We start to take the sutures from the inferior part of the cricoid cartilage, do it submucosally, and take the sutures upward to the upper part of the cricoid cartilage, and again we go through the inferior part of the thyroid cartilage and take it out through the drilled hole, or if the cartilage is too thin, we can do it. We can do the procedure with this needle itself without drilling a hole. And the obliteration is attained. The complete obliteration of the cricothyroid space is attained, and we should make sure that the final closure, the placing of the suture has to be done after removing the neck extension. Coming to the post-operative care, the drain removal is done as per any surgical neck surgical procedures when the drain is less than 20 ml. Suture removal on the 7th post-operative day. Voice rest as per any phonosurgical procedure for the initial first 2 or 3 days, followed by soft voicing. And we advise the patient to avoid sudden neck extension too. And we start the voice therapy after 2 weeks. Usually, since we are combining with an anterior glottoplasty, what happens is the patient may have a breathiness of the voice in the initial period, and for that, they would definitely require a voice therapy. Coming to our cases, because of the want of time, I'm presenting here only.
അതുപോലെ തന്നെ ഡോക്ടർ ഇത് നമുക്ക് സർജറി ചെയ്ത് കഴിയുമ്പോഴത്തേക്ക് നമുക്ക് അന്ന് തന്നെ പോരാൻ പറ്റുമോ, അതോ നമ്മൾ ഹോസ്പിറ്റലിൽ പിന്നെയും കുറച്ച് ദിവസം റെസ്റ്റ് എടുത്ത് അങ്ങനെയാണോ പോകാൻ പറ്റുന്നത് സർജറി?
ഹലോ ഡോക്ടർ, സോറി കേട്ടോ, എനിക്ക് വിളിക്കാനൊന്നും പറ്റിയില്ല ഡോക്ടറിനെ. കാരണം എന്താ വെച്ച് കഴിഞ്ഞാൽ ജോലിയും പിന്നെ ഇങ്ങോട്ട് വന്നതിൻ്റെ ഒക്കെ തിരക്കും.
ഞാൻ തൃശ്ശൂർ ജില്ലയിൽ നിന്ന് വരുന്നു. ഒരു ട്രാൻസ് ആണ്. ഇപ്പോൾ വർക്ക് ചെയ്യുന്നത് കേരള എയ്ഡ്സ് കൺട്രോൾ സൊസൈറ്റിയുടെ ഒരു TG പ്രൊജക്റ്റിൽ ഔട്ട്റീച്ച് വർക്കറായിട്ട് വർക്ക് ചെയ്യാണ്. വിചാരിച്ചൊരു നല്ല വ്യത്യാസം ഞാൻ ആഗ്രഹിച്ചൊരു വ്യത്യാസം എനിക്ക് കിട്ടിയിട്ടുണ്ട് സർജറിയിലൂടെ. ഞാനിപ്പോൾ ഹാപ്പിയാണ്. അതായത് വോയിസിൻ്റെ കാര്യത്തിൽ ഒന്ന് ശ്രദ്ധിക്കപ്പെട്ടിരുന്നു. അതായത് കോസ്റ്റ്യൂമെല്ലാം ഈ ഫീമെയിലായിട്ട് മാറിയെങ്കിലും വോയിസിൻ്റെ കാര്യത്തിൽ ഇത്തിരി ആൾക്കാർ ശ്രദ്ധിക്കുന്നുണ്ടായിരുന്നു ഒരു മെയിൽ ടച്ച് വന്നപ്പോൾ.
Thank you for your patient listening, and thanks for this great opportunity to present before you all. And I'll be happy to answer if there are any questions. And I would like to acknowledge my teacher, Dr. Jaykumar, who had come all the way from Trivandrum for the performance of the first case. Thank you all.
Good morning and namaste to everybody. Myself, Dr. Lata Devi, Professor and HOD, working in Department of Otolaryngology and Radionic Surgery, BLE deemed University, CBM Patil Medical College, Vijaypura. At the outset, I want to thank the organizers of PHONOCON 2022 for speaking on an interesting topic on assessment of voice by acoustic analysis, an ENT surgeon's perspective. Voice. What is voice? Voice is acoustic output from the vocal cord vibrations of the larynx and coloring it by the vocal tract, so-called, consisting of tongue, pharynx, trachea, and the lungs mainly. The sound of one's voice is personal signature. Size, shape, vocal tract, lungs, everything is important for modulation of the voice. Voice is also modulated by the race, age, gender, time of the day, emotions, culture, and region of the locality. Ultimately, what we can say, voice is a communication skill acquired laboriously throughout the growth of a child. It is the one which determines the personality and the career of a person in the society. Any change in the voice can cause hazard in the individuals, and it is because of various pathologies and requires thorough investigation and management. What we can say, the voice is the one factor which has made the Homo sapiens dominate the whole planet Earth. Why to assess the voice? For us clinicians, voice is much to be assessed because we want to know the patient diagnostics, severity of the disease, type of the disease, plan for treatment, and also it's required for legal purposes, post-operative comparison to convince and counsel the patient. How does we do the voice assessment? How does we do the voice evaluation? We start with history in any other case like a patient, go for a lot of laborious questions where how the voice changed, what is the onset, duration, then diurnal variations, age of the onset, allergic symptoms, hormonal changes, any voice abuse, professional commitments, all these determine changes in the voice. There are two types of voice assessment. One is the subjective, also known as perceptual voice assessment, which is determined by the loudness, pitch, intonation, and timbre, which is nothing but the quality of the voice. All these determine the subjective assessment of the voice. Of course, you know, we always detect the sound by the ear, that is the cochlea, the inner ear. We also know that it is one of the best voice analyzers. So any human can assess the voice whether it is normal or abnormal because of the cochlea, wherein already the frequency mapping is done from the basal turn of the cochlea to higher above in the brain. Then what is this auditory perceptual assessment of the voice? So we assess the voice by hearing the voice. A trained person who is already knowing about different types of voices will assess the hearing in definitive customized schemes like GRBA scheme, where the grades of severity of the voice like roughness, breathiness, asthenia, strain, everything will be determined given a scale of scoring. And there is also what is called as consensus auditory perceptual evaluation of the voice. And other customized voice schemes are there, Buffalo voice profile system, the RED, etc. But the main problem with these perceptual assessment is that they're all subjective. Trained persons also differ in giving the scoring. and the documentation is difficult. It cannot be reproducible once again. So there is a lot of interpersonal variability, and this causes lot of differences and comparison of the voices and future prognosis. Everything will be changed. That's why there is always search of objective evaluation of the voice. So what is this objective evaluation of the voice? There are two methods. One is the non-invasive method. The other one is the invasive method. Invasive method is the one which is done by us ENT surgeons. What we do clinically, routinely is indirect laryngoscopy, video laryngoscopy, flexible laryngoscopy we do every day, and video stroboscopy, which is nothing but the gold standard of voice assessment, wherein wonderfully we can know the tissue motion and viscoelastic properties of the mucosa of the vocal cord can be seen. And almost we can catch frames, 30 frames per second. The most advanced technique is the HSV, high speed video endoscopy, wherein we are going to get 4,000 frames per second. Slow motion of the vocal cord can be seen very much minutely also. Without regards to any type of dysphonia, we can catch the discrepancies in the tissue motion. So another non-invasive method is there, which is a simpler and the better way of objective method, that is acoustic analysis. What are the equipments used? Soundproof room, microphone, computer, laptop, software for recording and analysis. So there are many voice analyzing softwares like Pratt, WAGMI, Dr. Speech, MDVP, CSL. Okay. So we usually go for what is called as Pratt software, which is nothing but a freely downloadable software from the internet, which is internationally acclaimed open source software commonly used in most of the globe. It is most versatile application, can analyze and manipulate the sound waves. We can also extract 30 physical parameters of the voice. And we can also see the three-dimensional representation of the frequency with the time in what is called as spectrogram. The acoustic measures which are analyzed by the acoustic analysis is the fundamental frequency, pitch, speaking fundamental frequency, intensity, perturbation measures like jitter, shimmer, harmonic to noise ratio. Also, we can know the whole ranges of the frequency and the intensity, which is possible by an individual person, that is called as voice range profile, also called as phonotogram. What are these measures of perturbation? Any pathology in the vocal cords can easily be measured by differences in what is called as jitter, which is nothing but changes in cycle to cycle variations in frequency. Shimmer, cycle to cycle variation in the amplitude. Likewise, we have what is called as harmonics to noise ratio, also called as signal to noise ratio, where there is the energy of the sound in the form of ratio of periodicity to aperiodicity, that is noise. Now, I will tell you how exactly we have done the objective way of assessment, that is acoustic analysis of voices in our institution. First thing what we did was we created a normal institutional database using 1,500 normal voice samples from boys and girls who are college students from local institutions who are in the age of 18 to 28 years. And we trained them after coming to the institution in the sound treated room to spell sustained vowel for 3 to 4 times, hence trained them many times, and then recorded by asking them to utter the vowel once for 5 seconds, and analyzed the parameters like jitter, shimmer, harmonic noise ratio, and the mean pitch using Pratt software. Hence, we created a voice lab including acoustic analysis, and also we have video laryngoscopy and video stroboscopy, which is done to all the patients who are having abnormal voices or hoarse voices. Now, as I told you, the collection of data was in a sound treated room. The equipment used is a standard desktop computer or any laptop as such, and we used a standard unidirectional sonotone microphone, and a continuous sustained oval R was used for all the subjects for 5 seconds. And the recorded audio sample was opened in Pratt software, freely downloaded from the internet. A clean clipping of 1 second is extracted and subjected to extraction of a variety of physical parameters. Now, I will show you how exactly we do the voice sample collection from a patient. Can you please come here? For that, I go to the website Pratt E and then open the link here. The Pratt objects open up, wherein I want to record a new sound. So the new I'm clicking on, and I will ask the patient to go for recording mono sound. The dialog box will open for the recording option. I give the mic to the patient now and ask him to spell for 5 seconds by putting the mic about 5 centimeters from his lips and 45 degrees down to the lips. Now I will ask him to record. Will you please, Baba? I will stop it. Okay. I will save it to the list. And I will extract this sound. The most uniform segment of this, we have 6-second sound recording here, and I will take the most uniform segment of it. Let us say it starts from here, starting from 1.67 second, go to the 2.67 and more. Okay. And I will take this segment and I will save this file in WAV file. So it goes suddenly to the desktop or whatever the file you chose. I will name it as ABCD, and it will go to the desktop saved as a WAV file. Now I will close this dialog box and I will now open the file which I have stored in the desktop. ABCD. I will ask Pratt to open it. Now I will edit that file. Now this is the file which I extracted from the patient, and I will select the segment now once again for 1 second. Now I will go to the pulse, ask for the voice report. See, the voice report has already come here, which is nothing but a note file which gives all the recordings which are analyzed for parameters like median pitch, mean pitch, number of pulses, then jitter, which is the most important variation in cycle to cycle of the frequency, which is 0.7 here, shimmer 4.85%, then harmonic to noise ratio. Okay, these are all the parameters which come in the voice report. This note can be saved in the computer in the name of the patient at any time. So it will be saved in the form of ABCD, let us say, and can be used pre-operatively, post-operatively, like that. Okay, so this is the way how we collect the sample, record the sample, and analyze the sample for different parameters. Now I will close Pratt. So now we have collected in the same way 1000 samples for the normal voice database, and whatever the abnormal voices or hoarse voices which come in our OPD, we go on collecting with acoustic analysis, Pratt software, along with video stroboscopy and video laryngoscopy. Usually we note down for mean pitch, which is nothing but acoustic correlate of frequency, and jitter, cycle to cycle variations in frequency, shimmer, cycle to cycle variation in intensity, Harmonic to noise ratio is nothing but the ratio of energy in harmonics to the energy in A periodicity. Now, I was telling you, this acoustic analysis analyzes the parameters in the form of spectrogram, which is nothing but three-dimensional graphic representation of the frequency in the y-axis to the time in the x-axis. The grayscale, which is there on the spectrogram, is nothing but the intensity. Now, in our institution, we have male sample, normal voices 458, female voices 542. And we have normal range of parameters for male voices, which has come in this way. Pitch, the normal range has come as 106 to 167. Jitter 0.02 to 0.01. Shimmer and harmonic to noise ratio. We have normal range of parameters in 542 females, which are recorded as pitch for this 204 to 263. Jitter 0.003 to 0.01. Likewise for shimmer and the harmonic noise ratio. So this ongoing collection, recording and analyzing abnormal voices are occurring. Even all the patients who are entering into ENT OPD, we do this collection, recording and analyzing. So what is the summary of my presentation? So we have recorded the voices and analyzed the voices both in subjective evaluation as well as in objective evaluation. There are many types of assessment are there, and each assessment is different. Acoustic systems are very expensive. They are MDVP, multidimensional voice analysis, doctor speech, computerized speech lab, soundscope. Each is having different computer algorithms. Systems differ, and whatever the values and parameters which are given them are different. And the cost effectiveness also has to be seen by the ENT surgeons. So different algorithms are differing in values. So we have to have our own database in the institutions. That's why we have created 1000 normal voice database, and we are going on collecting the 250. Now we are existing having abnormal voice samples. So the software used is PRAT, which can record more than 30 parameters. Okay, we have done all this. What is the clinical implications of this study? This can also go for research work from existing normal and abnormal database. And we can compare and differentiate voices as abnormal or abnormal. And we can quantify the degree of hoarseness, disease progression. And we can monitor the effect of our therapies, either medical or surgical interventions. So they are complementary to subjective or perceptual measurements. But whatever it is, the limitations are there for acoustic analysis. They cannot be used as a diagnostic tool itself. They cannot be a standalone assessment tool. What is the take-home message? Acoustic analysis of voice is a simple, non-invasive technique which can be effectively carried out easily at any clinic with a good accuracy and reasonable prediction of symptoms. It's one of the objective tools for characterization of normal or abnormal voice that can be used by any clinician. Jitter, shimmer, harmonic to noise ratio are the parameters measured whose ranges give an idea of normality of the voice and can help the clinicians for characterization of voice into either normal or abnormal. But the comparison needs a normal voice database from the same institution. So what I can do is the proposal for a voice database, standard voice analysis tool, and a non-invasive method of voice analysis for otolaryngologists. These are the references which I took for my study during PhD. And I have done already some of the publications which regards to creation of a normal voice database, standardization of normal Indian voice parameters, and objective acoustic analysis of normal and abnormal voice comparisons. Good morning and namaste.
Here we come to an end of our session on voice. We thank each one of our eminent and distinguished speakers for the most enlightening and eye-opening talks on voice. It was indeed an enriching experience listening to each one of you.
Dear delegates, your questions will be addressed in a day or two kindly visit our website for the same. We would like to thank each one of you for being a part of today as well as yesterday. We also like to thank our educational partners, Atmos, Olympus, Bangalore ENT Trust, and CIPLA for helping us make this event a grand success. Now we would move to Hall A for the remaining sessions, including the Rising Star Award papers and the valedictory function. Thank you so much, all of you, once again.
When did it stop?